covering topics in the field of andrology. Please welcome with me the session chairman, Dr. Muhammad Hamouda, Dr. Abu Ajela Akra, Professor Gerard Vanderhurst. Could you all please join me to the stage? We will now commence our first session for today. All speakers are required to strictly adhere to their time limits, as previously illustrated in the conference booklet. Each speaker has his time limits pre-specified in the conference booklet. The chairman will assist in moderating and managing the time sessions. We would like to start off with our first keynote speaker, Dr. Liane Marie. She's joining us from South Africa. She's a senior lecturer in the Department of Medical Bioscience at the University of Western Cape, South Africa. She's lecturing second-year nursing students in human anatomy and physiology. She furthered her postgraduate studies at the UWC and obtained her PhD in reproductive physiology. She heads the comparative spermatology laboratory at Western Cape. She'll be talking about the potential of improving human sperm function in subfertile samples before assisted reproductive technology. Could you all please give a warm welcome for Dr. Liane.
Good morning, ladies and gentlemen. I just want to start off by saying thank you to the local organizing committee for making it possible for us to present some of our ideas and results here this morning. So we're from the Comparative Spermatology Group at the University of the Western Cape, which is close to Cape Town in South Africa. And our function of our lab is mainly to investigate or improve new techniques for analyzing sperm, especially sperm function. And this morning I just want to focus on one of the projects that we're currently busy with or has partly completed. I'm not sure this. Where was I pointed to? Sorry, we're just waiting for another pointer. It will help if you switch it on, hey? Right, to continue, I think most of you working in this field of andrology will know of the heterogeneous or the diverse nature of human semen. And the sperm is actually quite diverse in terms of maturity, the level of maturity, sperm functionality, and fertilizing ability. And it's only a small portion of the sperm in the semen that actually will be able to reach and fertilize the oocyte. So just as an example of how heterogeneous the semen samples is, I've just included pictures of what you will typically find if you have to analyze a semen sample in terms of the morphology and differences in head, tail, and midpiece defects that you would score for normality. At the bottom, we just see the sperm class analyzer, a CASA system that's automated and done some analysis to also see the differences in the head shapes and the acrosome coverage. If you look at motility, this is not a semen sample, it was a selection from a semen sample, but just to get the idea that there's also different motility subpopulations in our semen samples, ranging from very rapid progressive sperm in the red tracks, rapid sperm, less progressive in the green tracks, and then medium progressive in the blue tracks. Obviously, it also scores the number of static sperm. And then just in a study done to try and develop some semen quality scores, just to indicate the difference between fertile and infertile samples. So on the graph, the stars is 25 donor semen samples that was analyzed for a concentration, motility, and morphology. And the diamonds refer to infertile patients to show the large distribution of infertile samples compared to fertile samples. And that means that there's more diversity in the samples from infertile patients than from fertile or donor samples. So the female reproductive tract is responsible for then selecting this group of, or the best sperm, or the most or fertile or potential fertile sperm. I like this little comic because it actually shows the female reproductive tract as an obstacle course through which the sperm needs to go until it reaches and fertilizes the egg in the end. And you can see each step of the obstacle course is the different parts of the female reproductive tract that the sperm actually need to pass, and then different tasks need to be evaluated. So different sperm characteristics will become important. Just to do the actual reproductive tract, thanks Prof. Enkel for that nice image. It just indicates from the time the sperm arrives in the vagina at the bottom, it goes up into the uterus and then finally finds its way through the uterotubal junction, going into the fallopian tube, and then at the ampulla is where the sperm will then reach, or hopefully find this oocyte to fertilize it. And during each section of the female reproductive tract, there is some selection going to take place in terms of morphology, motility, DNA integrity, and whether the sperm can become capacitated or not. So the female reproductive tract is therefore very important. And it also then, during the journey through the female reproductive tract, the sperm will undergo different structural and functional changes to actually become fertile and to fertilize the oocyte. So I'm just showing some examples of the structural changes that it needs to undergo. You can see at the bottom it says there the first sperm is leaving the testes, then it's entering the epididymis, where it gets some proteins added onto the head or the acrosome, and then finally, it also gets rid of its cytoplasmic droplet. Then during exposure into the seminal plasma, when it's ejaculated, there's some more proteins added to protect the sperm acrosome. And then finally, upon capacitation, when it's in the female reproductive tract, it will then change, the plasma membrane structure will change to reduce the cholesterol content, and also bicarbonate ions will get rid of some of the proteins so that it's ready for fertilization. The change in the pH will also help to stimulate the motility changes that the sperm needs to undergo. So the fallopian tube and the follicular fluid from the follicle or from the ovary plays a very important role in regulating or modulating sperm function, the sperm-zona pellucida interaction, as well as fertilization. So what happens during the process when the sperm enters the fallopian tube? It will then stay there for a short period of time until the oocyte is released or ready for fertilization. And during that time, different secretions from the fallopian tube, listed here in the table, will assist to keep the sperm vital so that it can survive. It will also then, under certain circumstances, either inhibit or stimulate certain sperm functions so that it either causes it to either capacitate or not capacitate for the acrosome reaction to take place and to improve sperm zona pellucida binding. The same is true for the contents from the fallopian tube. There's quite a lot of different contents or components in the follicular fluid, and lots of studies has been done to show that these components also have an influence on sperm function. So I've just listed in the table there's hormones, there's growth factors, interleukins, reactive oxygen species, different proteins, peptides, sugars, prostanoids that actually have an influence on sperm function. A very recent study on your left-hand side show how extracellular vesicles from the from the follicular fluid was extracted, and they exposed sperm to it, and it actually shows how these vesicles interact with the sperm membrane, specifically the acrosome membrane, to show obviously there's proteins and other substances enclosed in these vesicles. So there's definitely interaction with some of the secretions from the follicular fluid. So some of the changes that I just want to highlight, I'm not going to go into the detail of all these pathways. I just want to show you some of the spermatility changes that the sperm needs to undergo. So on your left-hand side, it shows that there's an immotile sperm. That's when it's still in the caput epididymis. As soon as it is going into the cauda epididymis, it starts becoming motile. So it needs to be able to swim. And you can see here at the bottom, there's quite a lot of changes in the molecular pathways that needs to take place for the sperm to be activate motility. And it's all these secretions from the fallopian tube and from the follicular fluid that will actually assist of changing these pathways. Then just ultimately you want to get the sperm to hyperactivate. That's a different type of sperm swimming characteristic, and that is needed for fertilization to take place. On the left-hand side, it just shows that there's various signals that will introduce capacitation from either trying to increase the amount of calcium that's released from calcium stores, or to interact with our cat spur channels on the sperm plasma membrane that will also allow more calcium to flow inwards, and there's a number of stimuli for that as well. So my question today is, during artificial reproductive techniques, there's no such real selection from the female reproductive system that takes place, and also there's not all these interactions with all the secretions from the fallopian tube and the follicular fluid that we have during normal conditions when the sperm is in the female reproductive tract. Now, different studies have shown that one can treat the sperm or the semen prior to ART, and I've just highlighted 3 there that is in the literature, but it's all artificial, sort of. It's pentoxyphyllin, caffeine, and prochrane hydrochloride. In our own lab, we've exposed the sperm to caffeine, and we've exposed it to procaine, and you can see the changes that happened in the sperm motility tracts, and it actually induced hyperactivation. We also showed in the graph that different sperm motility subpopulations reacted differently to some of these chemicals. The blue graph indicates highly motile sperm. Not a lot has changed in terms of the percentage rapid sperm, but the less motile populations, we could actually increase the percentage rapid swimming sperm, and that's the sperm that you want to select for fertilization. So these chemicals can improve it, but is it a good idea to use that for ART? So my question is actually, what about biological substances? Shouldn't we actually present secretions from the fallopian tube and the follicular fluid and see if we can improve sperm function, especially if there's a subfertile population or patient that does not have good swimming sperm? There's a problem with sperm motility. So to investigate this, we've tested the principle of firstly, we wanted to create human sperm subpopulations and then expose it to different substances and see what is the effect of these substances and can we improve sperm function. So the first step was with a double density gradient, I'm sure many of you use this in your laboratories, to select the most motile sperm population for art. We've created a similar situation. We've just managed to select a high motile sperm subpopulation from the bottom pellet, and then higher up we've used the sperm in a higher density gradient with showing that is the lower motile subpopulation. We then exposed it to the substances, and then we wanted to evaluate all these different sperm functions. And we think we've now shown, we published 2 papers on this, showing that we're the first group to actually investigate all these sperm motility or sperm functional and structural characteristics, ranging from vitality, motility, hyperactivation, inducing acrosome reaction, reoxidative species, mitochondrial membrane potential, and looking at chromatin intactness and maturity. And what we found is that, that is when we did CASA motility analysis. In the middle you see what the semen looks like, and then after density gradient centrifugation you create these 2 populations. On the left-hand side is the low motile, not a lot of motility happening there, and then the high motile on your right-hand side. So just in the graphs, showed 2 clear distinct populations, high motile and low motile, in terms of its motility parameters, and the same was seen when we evaluated all the sperm functional and structural characteristics. There's a significant difference between the high and the low motile fractions. So we know we've created these 2 populations, and then based on results from a proteomic study in 2014, where they've looked at 2 groups of samples. On the left-hand side, there's the asthenozoospermic samples compared to normospermic. On the right-hand side, there's non-migrated versus migrated. So this is more closely what we did. They just used a swim-up. We use now density gradient, but they still have 2 motility subpopulations. And what they found is that the differences in the proteins, different types of proteins, was very similar to these 2. If you look at the pie charts, the different colors and the sections are almost identical between these 2 groups. And they also looked at the location of, subcellular location of these proteins, and found that that's also very similar. So that gave us the idea that we can use we can use our low motile fraction as looking at something similar to a asthenozoospermic sample from a subfertile male. What we then decided to use is my previous slide showing all the contents of the follicular fluid, and I've just highlighted the chemicals that we decided to look at. I've put dopamine in brackets because it's not actually included in this publication that I've cited here at the bottom. But subsequently, it has been shown that human sperm do have dopamine receptors, and some studies has proven some changes in functionality if exposed to dopamine. So just some of our results. So I'm going to focus. We've done a study looking at the overall population, if you combine high motile and low motile, and I'm now going to focus only this morning on the low motile subpopulation, because that's our subfertile population. That's something that I think that's applicable for the audience, trying to maybe improve subfertile sperm samples. So after exposure to progesterone, overall the sperm motility and kinematics improved, hyperactivation improved, and the acrosome reaction was also induced. And the low sperm motile subpopulation, in that population, what we found is that the hyperactivation percentage actually increased in the lower motile population to such an extent that we did not see the significant differences between high and low motile anymore. So it improved it quite dramatically, so that it's very similar to what we find in the high motile. For myoinositol, which is a sugar, it improved the overall sperm vitality, and also induced acrosome reaction. Obviously, that's not ideal. You don't want the acrosome reaction maybe to happen before you've exposed the sperm to the to the egg. But it, again, in terms of the low motile subpopulation, the motility and hyperactivation improved until there was no more significant difference. Dopamine, motility, kinematics improved, hyperactivation and acrosome reaction. And interesting, with dopamine we found that both vitality, hyperactivation and mitochondrial membrane potential improved significantly in the low motile population, and the ROS significantly decreased, which is a good sign. And then lastly, sorry, wrong direction. Lastly, for prolactin, prolactin did not really show any difference in acrosome reaction, but it improved the lower motile subpopulation again until there was no significant difference for motility, membrane, mitochondrial membrane potential, and ROS. So there's more literature. It's not just us looking at this at the moment. There's other studies that came out recently looking at, for instance, dopamine treatment. Various substances from the ovaries were evaluated to see if it can improve sperm function. And also even not just looking at humans. This was a study done on hamster species showing that different of these biological substances improve the performance of sperm. So in terms of implementation, in a clinical setting, I'm not a clinician, so this has not been tested in the clinical side, but it's just maybe to give you ideas of what can be done and maybe try these things in the future. Is first of all, we need to know what we're working with before we can try and improve or change sperm function. So it's very important to identify the functional capabilities of your sperm or semen sample. And then the specific concentrations of these biological substances is very important. We exposed it to physiological concentrations to see what is the best concentration of each of these chemicals that we've highlighted. And we definitely saw that a certain concentration often has the best result. It's not just any concentration that you can use. Do you want to use individual substances or mix them up in a cocktail because they improve sperm in different functional characteristics so that you have the overall effect? Which art procedures will it actually help to assist in treating a subfertile sample before you do art? That is something that needs to be considered. Ultimately, you want to improve the fertilization success and the live birth outcome. I'm sure all of you, that's your main aim. You want a healthy, living baby. So is there any way that we can use these substances to get to that result? I think that's the main aim. Sorry, and very few studies, unfortunately, has included these chemicals or substances rather, to show that it has an effect or an improvement in fertilization rate and live birth outcome. But luckily there is studies being done, so it's still a long way, but I'm sure working together with clinicians we can work towards something that is useful. Just some of my lab partners and Prof. van Horst from our department. Thank you for your assistance and thank you for listening to my talk.
Thank you. That was Dr. Leanne Marie. Thank you for a valuable talk. Moving on, we would like to give a sincere apology for the absence of Dr. Timidayo Omalawi. She had some logistical problems in arriving to Tripoli. Today we would like to start off with our first oral presentation given to us by Dr. Muhammad Abu Ghela from Libya. He's a urologist and an andrologist. He's currently working at Al Bayda Fertility Teaching Center and is a teaching assistant at Umar Mukhtar University Urology Department. He'll be talking about the topic of follicle-stimulating hormone and age as predictors for positive sperm retrieval patients with azoospermia. Could you please join you to the stage? Stage is all yours.
Okay, good morning everybody. Today my research topic will be follicle-stimulating hormone and age as predictors for positive sperm retrieval rate in patients with azoospermia. This research was under the supervision of the Associate Professor Dr. Al-Haddad. Okay, let's first start with a background why the definition of azoospermia. What is azoospermia? The 5th edition of the WHO manual defines azoospermia as the complete absence of sperm in the sediment of a centrifuged sample. However, the American Urological Association has adopted a more accurate definition that states as no sperms after centrifugation of the power of 3000 x for 15 minutes and examination of the pellet. Prevalence. Azoospermia is found in 1% of the male population and around 10 to 15% of male diagnosed with infertility. Okay, FSH, follicle-stimulating hormone and age. Follicle-stimulating hormone and age are commonly used predictors for the positive sperm recovery rate. However, the use of follicle-stimulating hormone, precision value, and age as predictors for positive sperm recovery has been variable between studies. So let's come to the aim of the study. Okay. The purpose of this research was to investigate the effect of follicle-stimulating hormone and age for successful sperm recovery or retrieval. I think there's a delay in this. Methods, okay. The methods, data collection, a pilot retrospective medical record review has been taken. Data was collected from the 1st of October 2017 to the 1st of October 2021. 68 patients with azoospermia were included in the study. All were Libyan-aged men between the age of 20 to 48. Transabdominal sperm aspiration was conducted on 35 of the cases, and transabdominal sperm extraction was conducted on 33 of the cases. There was no intraoperative complication that happened to any of the patients. SPSS soft version 26 was used to analyze the data. What are the results of this research? Okay, demographic data of the participants. All included subjects had primary infertility. Duration of the fertility ranged from 2 to 14 years, and all were Libyan-aged men between the age of 20 to 48. Okay, sperm retrieval rate of all patients. From the 68 patients, 34 patients had successful sperm retrieval by both procedure, which is 50%. Patients who underwent transabdominal sperm aspiration from the 35, 17 were positive, which is a percent of 48.6. Patients who underwent transabdominal sperm extraction from the 35 patients, 17 was successful, which is a rate of positive 51%. So there was no significant difference between the two procedures. Okay, mean FSH level by results. Okay, here we can see there's a significant patient with low FSH, mean FSH level have more successful sperm rates from patients with high FSH level. The green here represents positive and the gray represents negative. The mean FSH level for negative patients was 16.25, while the mean FSH level for patients with positive sperm retrieval was 9.81. So there's a significant lower FSH level for patients with low sperm FSH level than patients with high FSH level. Let's come to the age group. We can find that patients aged above 40 had 71% sperm recovery rate positive, compared with lower age group between 30 to 39 and 20 to 29, respectively. Conclusion. Okay, low FSH level and higher age was associated with successful sperm retrieval rate. Further workout. Okay. Further studies are warranted to investigate the cause of low sperm retrieval rate among younger azoospermic male patients. Thank you very much.
That was Dr. Mohammed Abu Agela. Thank you for your valuable talk. Our next speaker will be Abdul Basit Sersi from South Africa. He holds a postgraduate diploma in internal medicine, University of Cape Town, College of Medicine, South Africa. He also is a master's student in the studies of children, family and society at the Faculty of Community and Health Sciences, University of Western Cape. He'll be talking about the topic of infertility from the perspective of the family and society. Could you give us a warm welcome?
السلام عليكم ورحمة الله وبركاته. خويا مورا وخندت ومكلكيلي ملويني and very good morning for everyone. This is my lovely supervisor, Prof. Nicolette Roman, at Western Cape University. And the bottom picture is the Grootskeur Hospital, Cape Town. It's one of the tertiary centers in Cape Town. So I feel like an African tiger chasing me to finish my presentation within 15 minutes. So let me just ride my jet and fly quickly. Okay, so this picture actually summarizes my presentation. It's very informative picture. It shows how much is the stress that the fertile couple face to get a baby after a long journey of treatment, social, psychological stress. So it's really an informative picture since they spend a lot of money, a lot of time to have this successful result. Yes. Okay, so this is a non-traditional definition of infertility. It's, the words in blue was taken from the mouth of infertile couples. So they said it's not a want. Having a family is a human need. And someone else said it's time-consuming experience. It's a second job. And someone else said, I feel like I was half a man because I could not have a kid. And someone else said this has impacted on feeling like I have failed my wife. So this is a really devastating experience to not having a children, going through a very stressful experience, treating the personal, family, and social stability. So there is a very significant link between infertility and marital disruption. I will speak about that later, and also it's actually up to 60% in some studies showed or revealed the domestic violence in infertile couples. Infertility in general, or actually most of the studies blames ladies as a cause of infertility, and they mentioned the man as fertile and secure. So it's additional stress among infertile ladies. Most of the infertile women suffer from stress due to the lack of social and family support. So I will speak about impact of stress on infertility. Okay, so in most of the studies show that post-traumatic stress accounted for 40%, and depression is up to 50%. And this is actually one of the recent study in Iran to show the percentage of stress and depression among infertile couples. Chronic stress is periodic in relation to menstrual period. So when it's time of fertilization, the stress goes higher, and once the fertile time of the period is out, then the stress goes down, and etc. So every month has more up and down or remission and relapse character. Psychologically, infertility links to hopeless and powerlessness, anxiety, depression, anger, uncertainty with the marriage. So always there is a fear that the marriage is not going to be continued, or it will be short-term marriage since there is a problem with having children. Infertility treatment also has a negative impact. We'll speak about that later in relation to the cost of treatment and successful or not, etc. So stress-related factors, age. Most of the studies mentioned as the age goes on, the stress is higher. only one study said as when the age is higher, then the stress will be less because people are more accommodated to circumstances, more accepting this idea more. Length of the marriage also has a negative impact. As treatment-related stress, in form of successful treatment or not, having a trustful health provider, education and employment. Most of the studies mentioned that higher educated people and employed people has less stress, and once it goes to low education and rural area or baseline occupations like cleaners, etc., so the stress is higher. Guilty feeling also has a negative impact on the stress. A lack of social support. So when we have no social support, that means the stress is higher, and the rate of stigma is significantly impacted the outcome of the treatment. Extramarital sexual activity also has a very, very significant negative impact. In some countries, the extramarital relations goes higher than 70%. In Muslim countries, mostly it's a polygamy has negative impact as well. So one of the stressful impacts of infertility is identity crisis. So I mentioned earlier that the man has a feeling of being half a man, and also ladies feeling like they did not consider themselves as parents. So that affects the infertility and increases the rate of stress. In some cultures, they recognize ladies as real women just after having children. Biological motherhood and fatherhood is the fundamental component of the family, and since the fatherhood has a sense of authority and being on control, so they have a feeling of losing this feeling with more stress related to infertility. Infertility affects quality of life definitely in many ways. Stress itself leads to depression and anxiety. Also emotional disturbance, plus the cost of the infertility. I feel like I'm stressing out also because the infertility conference, buying a new jacket, new shoes, a flying ticket, also adding extra stress. Social and family pressure. The infertile couple facing very stressful social life, especially from in-laws, mother-in-law or father-in-law. The cost of and the effectiveness of the infertility treatment has a significant negative impact in case of there is no hope, or let's say there always hope at the end of the tunnel, but there is some challenge. I will speak about that later. Family instability. Couples always blame each other. You are the cause of the infertility. As a man, I'm secured, I'm fertile. Also leads to spouse abuse. It's significant spouse abuse, especially in Uganda, Nigeria, and some studies. A loss of kinship. Domestic violence, physically, sexually, and psychologically, counted as 68, 60, and 70% respectively. Strained relationship between infertile women and her in-laws has also a very negative impact. So men tend to marry a second wife. That's quite common in fertile couples that add additional stress in the social life of the infertile couple. Emotional problems, anxiety, shame, frustration, feeling depressed, withdrawal, isolated. It's quite common side effects of infertility. Depression up to 50% in some studies. And the problem with the depression is poorly recognized, late diagnosed, and badly treated. Infertile couple tend to feel impatient, selfish, and jealous about the other people who have children, withdrawn, and also some studies reported aggressive behavior of the infertile couple against children, feeling rejected from the community, and it could also lead to criminal behavior like stealing other people's babies. As I mentioned earlier, community has discriminating ladies as a cause of the infertility up to 70% of the studies, but also men has significant side effect that we have to concern actually. Difficulty interfacing interacting with infertile couple. Some of infertile couples trying to adapt and accommodate themselves to overcome the stress. So they enjoy being alone, easily engaged, intolerable, and no need to care about. And they don't actually like to feel we are rejected or not, and they don't like to be looked after by other people. They always, some of them try to avoid any subject about the children. They also has emotional instability, and they feel like infertility is a privacy and a confidential issue, and they don't like to speak about it. And this is one of the important factors later on about social support and also trustworthy of the health provider. Okay, male factor. Infertile men feels half a man. They don't feel like they are normal men, and it subsequently affects the mental well-being. They highly discriminated as being half a man. Sense of male failure and less respect, especially by female partner. Not all the studies. Silence and the stigma interfere with seeking and gaining support. So men are more sensitive than ladies to seek medical advice. They always taking a step back, not to speak about their infertility problem. And maybe ladies are more brave than men in this point. Infertile men are seen as a subject of ridicules. They've been rejected by the community in some countries in Africa, especially in Tanzania. It's not only just male and female factors. We have adoption-related stress. So I'm not going to speak about the religion point view of this, about adoption. We know that there is some restriction in Islamic religion, but in general, I would just want to speak about this point in social point of view. So infertile couple are always considered infertile despite having adopted child or not. And stress-related, adoption-related stress also related to once the child is getting older, then the child will request to know who is my biological father. That also increases some stress to the parents. Risk of child abuse or adopted child abuse is very high. And mixing lineage, that's related mostly to Islamic culture. Okay, stigma related to infertility. In Malawi, they call lady Shomba and the man Goju or Joju, or something like that. That's a specific name for someone who has no child. So it's a formal name for someone who has no children in Malawi, unfortunately. Yes. Okay. So reproductive capability of the men to be unquestionable. So men is fertile and secured, excused from stigma and discrimination. That's the rule of the culture of the community. Abuse and avoidance of childless person. Usually the rate or the chance of remarriage of the infertile women is very, very low and has no chance to have the person that she would like to marry. So the chance of having the right person is very low after the first marriage. Infertile women are not permitted to touch or cuddle the newborn baby in some countries like Tanzania. In South Africa, we have a baby shower. It's a little bit different to Libya. In bracket, we call it sbuh. So this baby shower is always before the baby born, and it's a kind of social support for the pregnant lady to have some new clothes, food for the baby, to support her to have a new life with a new baby. So this is very significant discrimination and stigmatizing infertile ladies in Tanzania, Nigeria, not to allow infertile ladies to touch or to attend baby showers, unfortunately. Husbands are always encouraged to take the second wife. There was a questionnaire in Pakistan. The 57% of ladies in that community agreed that the husband allowed to have the second wife, and 70% of the men who attended to this study agreed for the male to have a second wife. There was no study in Libya about this point, but it's definitely 0% for the lady to be agreed to have the second wife. Risk of stigma is low education. Education is very important. So highly educated people are less stigmatized. Low educated people are highly stigmatized, especially in rural area. Women's occupation, so doctors, teachers, engineering are less stigmatized, while the ladies or men who works in a daily work or handworks are more exposed to stigma. Infertile women in the rural area, definitely, because the community tend to be smaller and the words can spread so quickly and more stigmatized, and the rate of remarriage is very low and abuse is very high. Highly fertility-related stress also impacted the stigma. So as more as the stress, the stigma is more, and also related to depression and anxiety. A treatment, also a duration of treatment of infertility. So once the treatment takes long duration, then the people start talking more and more stigmatizing the ladies specifically. So in Mozambique, ladies are always excluded from certain social activities. In India, 70% of women experience physical violence due to their failure. If we agree that it was their failure, they do not actually agree that it's a male and female problems. In Karachi, 67% of fertile women suffering from stigma and marital conflict. More than 20% divorce, threatened by divorce and remarrying, and they send ladies to their family house by their in-laws. Okay, social aspect. Okay, in a survey of 17,000 ladies in 10 countries, they found that there is a poor knowledge about infertility, especially the infertile period of the infertile time or during the menstrual period. Traditional medicine is very important. I would love to have more slides about this, but I was told it must be less than 15 slides and 15 minutes, etc. So I had no chance to go further. In Nigeria, Rwanda, Angola, Uganda, Nigeria, Rwanda, people seek the traditional healer in percent of 76, 69, and 11% mostly after the first medical visit. So the chance, or actually the rate of visiting traditional healer is higher after the first visit, first official medical visit. Perception and beliefs about infertility. Infertility is not a medical disorder. That's the belief of some communities in Karachi and Pakistan in general. And having children is just blessed by God, by Allah. It's not a problem. So that has significant negative impact on seeking medical advice. Women are considered as handicapped or witches because they have no children. Supernatural cause is also considered as a cause of infertility. As a Muslim, we believe in jinn, but there is a study in United Emirates, actually 2 studies by the same professor. They mentioned the supernatural effect of the jinn on infertility. They mentioned that 30% of people in United Arab Emirates believes on jinn as a cause of infertility, and 40% believes on black magic as a cause of infertility as well. Misconception eventually lead to sexual in Tanzania. Because of the culture and perception about the infertility, they have misconception about infertility and sexual malpractice. They force ladies to stand on one's head and eat dirts and inducing vomits. And I did not want to say in bracket what is the dirt. They have been.
Conclusion, please. We just need the conclusion. Could you just round up, please?
Okay. Religion also. Okay, I think there is only one slide left. Religion, it's important in Iran by Mufti Al-Khomeini. He accepted a third-party donation in infertility. Okay, treatment-related challenge. The most important in this slide is health provider factors. So most of the clients always complaining of there is no time and good counseling by the by the medical provider, and they always say they don't even listen to you because the busy schedule. Stress during treatment, it's related to duration of treatment, availability of treatment, and successful of treatment or not. Social support has very important, has positive impact and negative impact. Positive impact if the infertile couple has a very good support, and it's negative impact if there is a social conflict and risk of the divorce. Support I just mentioned now. Direct disclosure is very important, and trustworthy of the health provider is important. Education of the community has very important impact on the infertility. And this is my take-home message. I'm sure you remember this message. جزء من النص مفقود. That means social impact on the infertility is very important, and we have to consider it as a part of the treatment pre-treatment counseling, post-treatment counseling, post-treatment depression treatment, etc. It's very important. We do not need only to focus on treatment of infertility, but we also need to focus on the social circumstances of the couple and the stress they face on a daily basis. Thank you so much.
Thank you. That was Dr. Abdul Basit Sasi.
So my jet was very slow.
It's okay. I would like just to remind our speakers to try to adhere to the time. Our next speaker will be Dr. Nada bin Rhayyim from Libya. She will be talking about the topic, the combined effects of lifestyle intervention and antioxidant therapy on the sperm DNA fragmentation. Stage is all yours.
Assalamu alaikum. So, in the first, my topic today is talking about the, where's the stage, please? is talking about the combined of effect, the DNA and the effect of antioxidant treatment for the patient, for the infertile patient. So the combined effect of lifestyle intervention and antioxidant therapy on sperm DNA fragmentation under supervision of Dr. Dohaneida Al-Mijrab. She is my mom before she was my doctor. So in the beginning, we will talk about the introduction. Oh, sorry. As we know, the male infertility accounts for approximately 20 to 30% of infertility cases. However, combined with female factor infertility, it contributes to at least 50% of infertility cases. The male infertility involves a broad consecutive spectrum, including infection, endocrine disorder, cryptorchidism, genetic condition, and varicocele. But in up to 50% of cases, the cause of male infertility remains unknown. So, an important contributor to male factor, the infertility is sperm DNA fragmentation, which is generally not routinely assessed before or during infertility treatment. So the DNA, it has been shown that more than 20% of normospermic males have a DNA fragmentation index more than 27%, resulting in decreased chance of conception after intrauterine insemination. Moreover, in vitro fertilization success rates are lower in men with high DFI. A recent meta-analysis comparing IVF and or ICSI success rate in men with low and high DFI reported higher clinical pregnancy rates in favor of the low DFI group, regardless of fertilization method. For IVF and the ICSI, the percent, it seems the 95%. So we have two types of DNA stranded fragmentation, single and double. The single is mainly caused by oxidative stress, tobacco, alcohol, and it's much more extensive error affecting a large part of the spermatozoa DNA. This makes it very difficult to repair by the oocyte, and therefore not even the gestation occur. In the case of double-strand fragmentation, breaks are produced at specific points that are unprotected by enzyme. It's called the nuclease. So the damage is not so extensive and can even be repaired by a young egg. Otherwise, if this fragmentation is not repaired, it will give rise to an embryo with chromosomal alteration that will most probably end in miscarriage. The intact DNA in the A and B and C, the single and double strand breaks. And in single and double, they share the breaks not attached to the nuclear matrix. So the protamine and histone can be affected. But in the single, they will give us the high number of DNA breaks and high number of affected sperm. But in the double, they will give us the high number of DNA breaks, but the low number of affected sperm. Sorry. And there's causes of the DNA fragmentation. There's extrinsic and intrinsic factor. The extrinsic factor, it's mainly heat exposure, smoking, alcohol, environmental pollutant, and chemotherapeutic. The intrinsic factor is defect in germ cell maturation, abortive apoptosis, and oxidative stress. The oxidative stress is a major contributor to male infertility, and reactive oxygen species are vital for physiological processes such as apoptosis and capitation, but an overproduction leads to various deleterious consequences, including SDF. As we know, the sperm is contained of head, neck, and tail. So in the head, we have a protamine and histone rich. In the normal people, in the normal men, they have the protamine, it's about 85%, and the histone rich is about 15%. But in infertile men, the histone is higher than protamine. And there's a lot of study finding that there's a 5 to 10% of the infertile men don't have the protamine at all. Our material and method, we conducted a prospective study. It was done in Lamar Clinic in Benghazi between October 2021 to October 2022, involving 149 from 300 sub-infertile and infertile males with a history of failed IOI, IVF, and ICSI trials for no apparent reason. resulting in either embryo development arrest, implantation failure, biochemical pregnancy, or miscarriage. There is a 10 healthy male volunteers served as controls. Semen analysis was carried out according to a 2021 WHO manual, where seminal was normal. SDFY assessed by sperm chromatin structure assay. Participants with DFI more than 30% underwent a 3-month lifestyle intervention program primarily based on diet and exercise. A 3-month lifestyle intervention primarily based on diet and exercise combined with oral antioxidant therapy using multivitamins, coenzyme Q10, omega-3, and oligo elements like vitamin A, vitamin E, selenium, zinc, that's all. So about the result, we have just 13 minutes, so I'll be, there's a limited time. So the results show that there is, it depends on 50 and 50. The treated patient, it was a 49.66. So it's a total of 149 of 300 patients. It's about 49.6% had a DFI. More than 30% participated in the intervention program and treated with antioxidant therapy. From those of them, 30 patients, it's about 20% were conceived, 28 patients was spontaneous pregnancy, and 2 of them with the IOI program. About the age, the most common age was affected with the DNA fragmentation. It's between 40 and 49. The percentages was 43%. The type of infertility, the most common males was come to our clinic is they was a secondary infertility, and it's the percent it was 74. The smoking, as we know, all the male. So the smoker, it was the most percent is 9. It's about 59%. The discussion, and it's very important. SDF is an important factor that can influence male reproductive potential and affect reproductive outcomes. The implementation of SDF testing in clinical practice can be done for investigative or protective purpose and can also allow targeted management strategy. Unfortunately, it is common practice in many arts centers to neglect fertility evaluation of men with normospermia or those who have spermazoa available for ICSI. This can lead to several failed art cycles before referral to urologist or andrologist is done for male factor evaluation, promotes assessment of the male partner, including the level of SDF, may allow early identification of underlying pathological factors, and can direct toward targeted treatment paths, reducing the cost and burden of unnecessary intervention or repeated failed art. There's several studies support our study, and this study with around Ital, it's talking about the sperm DNA damage is associated with an increased risk of pregnancy loss after IVF or ICSI. They say that sperm DNA damage is associated with a significant increased risk of pregnancy loss after IVF and ICSI, and it's same like our study is talking about a 3-month lifestyle, talking about the Peter et al. 3-month lifestyle intervention program combined with antioxidant therapy reduced the DFI in fertile men with elevated SDF and a history of failed IVF and ICSI. A personalized lifestyle and antioxidant intervention could improve fertility of subfertile couples through a reduction in DFI. Our conclusion, we hear and report that a 3-month lifestyle change and antioxidant therapy program significantly reduced the DFI. This effect was statistically significant compared to a healthy control group who delivered semen sample 14 days apart without any lifestyle intervention. Personalized lifestyle and antioxidant intervention may potentially improve the fertility of subfertile couples through an improved DFI. Albeit larger control trials evaluating pregnancy and live birth rates are needed before firm conclusion can be made. Our reference. Thank you so much.
Thank you. That was Dr. Nada. Moving on, we'll be moving now to the discussion. It will be governed by the chairman. It will last for 15 minutes. So if anybody has a question, could they please raise their hands?
Thanks, Dr. Nada. Very nice work. Are you recommending routine sperm DNA fragmentation for evaluation of infertile couple? Where is Dr. Nada? Yes?
Sorry, doctor, if you can repeat the question.
Are you recommending routine sperm DNA fragmentation testing for evaluation of infertile couple? Yes, I don't agree. The indication of sperm DNA fragmentation, according to the European Society in 2021, are three. Number one, recurrent pregnancy loss. Number two, idiopathic male infertility. Number three, varicocele. Shukran.
Thank you. Sorry, would you like to respond to the disagreement? Okay, good.
Sorry, thank you for your question. We are just at not routine. No, it is not routine. It is not routine. And you know it is not routine. Sure. Yes.
Because I misunderstand. Sorry, I'm so sorry, doctor.
Is the misunderstanding sorted out?
Okay, I would like to thank Dr. Sassi for his present lecture about the social support for this group of people. We've been managed for the last 25 years. I'm talking about in Libya, and I think same problem worldwide. We have experience in Benghazi. We have society called El Ajyal, worked for 5 years, and we have social advisor, psychological advisor, and they have very nice work in this field, stopped after February. All this work has to be done by you as infertility specialists. You have to support this couple until you have good society in your city. And that will be very good practice. That's only my comments. My question to Dr. I forget his name, urologist, about the doing TISA or visa. Yes, about FSH and azoospermia. I would like to know what was the quality of sperm retrieval when you have high FSH. The quality of sperm was not mentioned. That will give you an idea about success of relation between FSH and the retrieval of the sperm, please.
Regarding the positive sperm retrieval, I don't think so.
Let's try this one.
Okay. Positive sperm retrieval, even if you retrieve one sperm that is abnormal morphology and with no motility, is considered positive. Negative is no spermatozoa, even in the histological specimen or biopsy taken from the testis. So when we found even one spermatozoa, we considered this positive sperm retrieval. Are you satisfied?
Are there any further questions? Otherwise, I would also like to make a comment.
Excuse me. Regarding the sperm extraction, do you use microscopic sperm extraction or the in case of FSH high, of course, or just do FNA? Can you tell me that? Do you use microscopic extraction? You open tests like a book and take the samples from the tests, or just do FNA just by the needle? Who answers? Sorry.
Question from the beginning. Can you repeat the question from the beginning, please?
My question, sorry. I asked you, when you take the sample of the test, do you use microscopic extraction of the, do you open the test like a book or just do FNA by the needle?
No, there was two procedures that were carried. The first was transepidemic sperm aspiration, which was by an FNA procedure as you just mentioned. And the second was transepidemic sperm extraction, where the testis was open, but it was not microscopic. It was only open TZ.
It's not right.
Okay.
Okay.
Are you're not happy?
No, I don't agree with that. You have to open the book like, open the test like a book and do microscopic extraction.
Yes, we did before microscopic
You can't
extraction.
see without microscope, you know.
Yes.
Okay, I just want to make a general comment unless there are somebody who wants to ask an emergency urgent question. I really need to summarize the session as very, very, very encouraging to see that, you know, recently somebody high up in WHO said that we don't want success rate in fertilization and live birth outcome. In the end, we want an outcome with a happy, healthy baby. And I think all these things from Dr. Liana Maria's project, right up through the psychological aspects, right up through selection, are ones that's trying to gear and get a real good rationale for better sperm, probably for a better outcome. I think it's really important. Thank you for all those speakers who've really contributed in a major way.
Assalamu alaikum. I have one question or two questions for Dr. Nada. I'm very encouraging. I'm very happy to see this kind of
Sorry, where's the
researches.
speaker?
Here.
Oh, can you stand up, please?
Yes.
Oops.
Yes. Sorry. First of all, I'm very supportive for this kind of researches, but I have two questions. It's not more. It's not words, not more than a question. Regarding the interventional researches, you have to take care about the area of study design. You have to be more careful to describe that you have got the consent and ethical approval. I don't know if you have covered this issue. This is my first note. The second question, you have spoken about the smoking. I don't know if you have covered the passive smoking with your research or not. Thank you very much.
Sorry. Is the response, you want a response? Okay, last one. We closed. The time is run out.
Yes, it's
Sorry.
okay, but it's covered with the passive smoker and everything is recommended that. Thank you, Doctor.
Okay, unfortunately, we need to stop now. Thank you.
Okay, so this concludes our first session. Thank you all for your attention. You're all invited now to the coffee break. We would like to notify you that the coffee break will extend for only 30 minutes. I hope everyone can find their seats within that time.
تمام.
Okay, continuing our sessions, the next session will discuss the major theme of reproductive medicine. Without further ado, we now present to you the chairmen of the session. Professor Ghzayil Al-Haddad, Professor Zahia Al-Ghazal, Dr. Sahar Abdul Rasul. Could you all please join me to the stage? Is Professor Ghzayil present? We will now start with our first speaker for this session, Dr. Yasser Yunus. He's a consultant obstetrics and gynecology in Egypt. He's also the head of assisted reproductive technology at Injab Fertility Center. He is a member of the American and European and Egyptian fertility societies. He is the inventor of the oocyte retrieval and embryo transfer stimulator. He is the founder and CEO of Lotus Nile Valley Academy for Development and Continuing Medical Education. Could you all give us a warm welcome, please? Dr. Yas will be talking about the key performance indicators in assisted reproductive technology, which is more effective. Thank you.
السلام عليكم، ازي حضراتكم؟ انا طبعا يسعدني ويشرفني ان انا اكون موجود في وسطكم النهارده. مؤتمر قوي جدا وناجح جدا ما شاء الله، تنظيم على اعلى مستوى. والكلمه اللي انا كنت بقولها اول ما ربنا سبحانه وتعالى يعني اكرمني وجيت ليبيا، ان انا فعلا بقول ان ليبيا تستحق. فمتشكر جدا جدا على الدعوه الكريمه استاذ الدكتور محمد سعيد المحيشي والدكتور عبد العزيز، وان شاء الله اتمنى لكم كل التوفيق. المحاضرة بتاعتي النهاردة يعني اسمحوا لي ان انا اخرج بس شوية عن نطاق البدلة والجرافطة. انا ليا طريقة عرض في محاضراتي، فاسمحكم ان شاء الله انها تكون مختلفة شوية عن بقية المحاضرات. المحاضرة Key Performance Indicators in ART, or what we call the art of perfecting ART. Really, the ART is an art, and it has its rules, and we have to perfect it to give our outcome as we wish and as our patient wish. This picture, I'm from Mansoura. This is my city in Egypt, Mansoura, and I have the honor to be one of the sons of this city. This picture is the University of Mansoura, and this is the River Nile in Mansoura. Mansoura really is a great city and has a great sons who have a very impact in the culture in Egypt, like Sheikh Mohammed Mitwalli Sha'rawi, فضيلة الشيخ جاد الحق علي جاد الحق, Dr. Mohammed Ghunaim Urology Center in Egypt, and most of the art legend in Egypt are from Mansoura. From my first visit here, I went to مصراتة. الحقيقة في الفيديو امبارح اللي شفته الأماكن الجميلة بتاعت ليبيا، أماكن كلها جميلة وعظيمة جدا. في مكان رائع وأتمنى إن كل اللي بيجين يزوروه، وما أعتقدش إن في كتير يعني راحوه لأن أنا رحته. هو المكان ده هو مسجد الإمام فضيلة الإمام سيدي أحمد زروق في مصراتة. وفضيلة الإمام أحمد زروق ده يعتبر كان إمام المالكية ودرس في الأزهر، كان شيخ عمود في الأزهر الشريف، وكان بيحضر الدرس بتاعه 6000 طالب علم، وكان هو إمام المالكية في مصر، وهو من كبار أولياء الله، وجميع علماء الأمة حريصين على زيارته. وآخر زيارة كانت زيارة الأستاذ الدكتور علي جمعة مفتي الديار المصرية فيه، وأنا الحقيقة اتشرفت إن أنا رحت وقابلت الدكتور حسين أبو عجيلة، ده ابن الدكتور مصطفى مؤسس المسجد والمكتبة. في مكتبة رائعة، أقل ما يقال إنها رائعة، قاعات في معظم أنواع العلوم، مش العلوم الدينية بس، وحاجة جميلة جدا، وأدعوكم جميعا لزيارتها. البوينتر فين يا جماعة؟ ما بيشتغلش. Okay. So our lecture is how to be successful in IVF and ICSI. Really, to answer this question, we have many sides or many parties have a different point of view to answer this question. IVF and ICSI is a process in which multiple parties are involved. Clinicians, embryologists, infertile couple, wife and husband, drug companies, and stakeholders. طبعا الستيك هولدرز اللي هم الانفستورز اللي بيعملوا مراكز الحقن المجاري، مش الدكاتره الغلابه يعني. تمام؟ if you ask a clinician what's your opinion about successful IVF and ICSI? Okay. Oh, sorry. في سلايد ليه؟ لا مش قدامي دي. هو بيعلق ولا ايه يا جماعه؟ في سلايد مش موجوده يا طه. نو اللي قبلها سوري. اللي قبلها على هو طب هي عموما السلايد انت بتسال كلينيشن انت ايه وجهه نظرك في السكسسفول اي في اند اكزي، فبيقول لك العينه تعمل اختبار حمل ويجيب لك اختبار الحمل دي نجحت، او ان هو يعمل لها الترا ساوند ويلاقي بالالترا ساوند فيه 1 ساك او يلاقي فيه 2 ساك او يلاقي فيه 3 ساكس. اوكي، وبعد كده يولد العيانه ويشيل 4 بيبيز وينزل على الفيسبوك ويقول لحضرتك الحمد لله الذي بنعمته ايه تتم الصالحات. عندنا سيده عمرها 92 سنه تعاني من العقم منذ 88 عام وتضع 4 توائم بالحقن المجهري ومن اول محاوله. 92 years old lady suffering from infertility from 88 years and got 4 babies from the first trial, and I am the strong man, right? Okay. From the embryologist's point of view about successful IVF and ICSI, he gave me a good quality embryos either in day 3 or day 4 or day 5. And from the patient point of view, we have infertile couple, right? From the wife point of view, she wants to have a baby. That's all what she wants, right? And what about her husband? Her husband wants to pay less money, right? Okay, and he looks like this vision to you when you pay for IVF and ICSI. And the point of view of the drug company, from the drug company doctors, what is their point of view about successful IVF and ICSI? I think you know, to sell more and more hormones, right or no? Okay, and from the stakeholder point of view, دول الانفستورز اللي عملوا مركز الحقن المجهري، كويس؟ الحقيقة الديفينيشن ده, this is my definition for stakeholder. Really, when I asked one of them, please, what's your opinion about successful IVF and ICSI? He said to me, I will tell you the definition of IVF and ICSI from my point of view. Well, and to be honest with you, it's a process in which we can easily transfer money from pockets of infertile couple, passing through clinician and the embryologist, to our bank account, making in consideration 2 points. Number 1, low operating cost. Number 2, maximum return on investment. And this is the stakeholder point of view. Looks like that. Okay, to empty the pockets of infertile couples and their wallets and put their money in our bank account. طبعا البنك الأهلي المصري أعرق بنك في مصر وده بنك أهل مصر. Okay, but let's put this success under microscope and examine it and what our point of view to successful IVF and ICSI. Really, let's put our success on a scale. Measurement is an essential management tool. It helps us determine our work is making an impact, demonstrate value, manage resources, and focus on improvement and effort. Key performance indicators are the critical key quantifiable indicators of progress towards an intended result. And managing with the use of key performance indicators includes setting targets, the desired level of performance, and tracking progress against those targets and support quality improvement process. But one moment, please, before talking about KPIs. Before we agree and select certain KPIs to use in our IVF centers, do you have a quality management system in your IVF centers? If you ask this question to most of IVF centers in Egypt, and I think here in Libya, and in most countries all over the world, they said, really, no, we don't have a quality management system. But maybe someone of you say, okay, quality looks good, but is it mandatory to implement the quality principles, which is plan, do, control, plan, do, check, and act in our IVF clinic? Is it mandatory? All I want as a clinician to my patient to get pregnant. So, and this is what I need, right? But quality management system, why bothering you with this system? I will ask you, are you committed to provide excellent service in your IVF center? Simply, do you want to ensure smooth functioning of your operations? Do you want to increase your efficiency? Do you want to ultimately improve clinical outcome in your center? Do you want to increase both the employers and the patient satisfaction? If the answer is yes, okay. Additionally, and much more important, do you want to be accredited with local and national authorities? Quality management system is an important part if you want to have ISO to your system, to your center, so you have to implement quality management system in your IVF center. And ISO 9001 28 is says that all ART clinics must have and implement a quality management system as a bare ISO standard. Total quality management system, it includes continuous evaluation of all process in your IVF center, from when a patient enter in the IVF clinic and to when outcome to their treatment is communicated and has been completed. It involves implementing a standard operating process and set performance and the quality indicator to each process in your IVF center. Also, it includes documenting and monitoring and analyze all performance and timely identify for any errors or deviation from the set values and take necessary corrective action to ensure the continuous improvement of the entire system. Although quality management systems have proven effective to increase the efficiency and reliability, outcomes, safety, as well as cost effectiveness, it is yet to be universally adopted by all ART clinics. So, and what's key performance indicator? According to the approach of the Institute of Medicine to quality in healthcare, identification of reliable quality indicators is a crucial step in enabling users to quantify the quality of a selected aspect of care by comparing it against a defined criterion. A performance indicator is thus an objective measure that potentially evaluates all critical care domains defined by the Institute of Medicine. Patient safety, effectiveness, equity, patient-centered tenderness, timeless, efficiency. These indicators must be based on evidence associated with those domains and can be implemented in a consistent and comparable manner across setting and over time. Essential for key performance indicators are essential for evaluating a process, and it is necessary to map all the process in your center, describe all procedures involved in the process, and define the performance target for each process. الحقيقة أي خطوة حضرتك بتعملها في السنتر أنت حتى كدكتور لازم كل حاجة تبقى مكتوبة ونقسم جميع البروسيس تتقسم إلى خطوات والخطوات دي تتحفظ ونبدأ إن إحنا نشتغل على الخطوات دي. Then we monitor each which is a process to able to identify a deviation, then being able to act and prevent such deviation to exceed certain limits. This plays an important role in avoiding adverse consequences and maintaining optimal performance. Key performance indicators in ART, all of us strive to deliver improved clinical outcome to patient. Based on KPI concept, IVF center must stick to a group of clinical and laboratory parameters, which can be used to establish minimum standard for proficiency and for benchmark as part of their internal quality control. Such standards are needed to enable continuous improvement. Most professional bodies of the ART industry, such as the ISHRI and the Association of Embryologists, have in their good practice guidelines in clinical embryology stated that all IVF centers should identify and follow reference marker of its activity to allow evaluation and continuous improvement that should be performed at a specified time interval. And various investigators have outlined several quality indicators for infertility care to measure contribution of the different health professionals involved in ART. These indicators include both laboratory work and the clinical steps of ART. And as we see, KPIs is considered as the building unit of a quality management system. If you want to have a quality management system, you have to start with a key performance indicators. Okay, clinical KPIs. We will talk briefly about clinical and laboratory KPIs. This consensus of a Maribor consensus, Maribor is a city in Slovenia, and an expert meeting was held there by the ISHRI Clinic Performance Indicator Working Group, and they have agreed that a clinical practice in ART should have the following indicators. This paper was published in Human Reproduction, Maribor Consensus, report of an expert meeting on the development of performance indicator for clinical practice in ART. The Maribor Consensus for clinical key performance indicator recommend 6 performance indicators to be used for monitoring clinical work in ART, including all steps like ovarian stimulation for ART, embryo transfer, and pregnancy achievement. We see cycle cancellation rate. As a clinician, it's not sufficient for me to tell me, okay, my patient is pregnant. I want to ask you, what's your cycle cancellation rate before oocyte pickup? And what's the rate of cycle with moderate and severe ovarian hyperstimulation syndrome? What's the proportion of mature oocyte at ICSI? And what's the complication after ovum pickup? And what's your clinical pregnancy rate? And of course, what's your multiple pregnancy rate? Your multiple pregnancy rate is a negative impact about you, right? So the picture in the first slide, as I told you, a doctor carrying 4 babies, and he said, okay.
Sorry, doctor, I have to interrupt you. You are about to finish your time.
Okay,
thank you.
Just 5 minutes, 5 minutes.
Too long. You're going to have to wrap up in 2 minutes.
Okay.
Please.
So multiple pregnancy is a negative stigma on you, not a positive sign. These are the 6 KPIs they told us, okay? And also they defined the frequency to measure these KPIs. Some rates, we measure it for about 100 cycle and or 6 months, which come first, and other indicators, we should measure it per 50 cycle or every 3 months, which come first. Okay? This is another paper by Rita, published in Fertility Sterility about also clinical key performance indicator clinically. They add the patient to population type to the and various ART procedure and adequate ART outcome indication. يعني ما تجيش حضرتك تقول لي ده انا العيانين بتوعي بيحملوا وبتاع، قول لي بقى حضرتك الشريحه بتاعت العيانين الديموغرافيك بتاعتها كام؟ الايدج جروب بتاعتها ايه؟ الكوز اوف انفيرتيليتي ايه والكلام ده، وبناء عليه نبدا نقول حضرتك سكسسفول ولا لا. فده الجروب دي. بعد كده اللابوراتوري كي بيرفورمانس انديكيتور عشان ما اطولش على حضراتكم. برضو عندي كان في فيينا كونسنسس في 2017، ده برضو الاشري سبيشال انترست جروب اند الالفا ساينتست برضو عملوا ميتنج كده، والميتنج دي كانت في فيينا، وحطوا برضو كي بيرفورمانس انديكيتورز للمعمل، لشغل المعمل. وهم حطوا 19 الحقيقه 19 indicators to measure the work of a lab. دول اللي كانوا مشاركين، الاكسبرت كانوا مشاركين في الميتنج. دول certain KPIs. طبعا من ضمنها هي ايه بقى؟ عمل ايه؟ الاكزي دامج ريت والاكزي نورمال فيرتلايزيشن ريت والاي في اف نورمال فيرتلايزيشن ريت، الكليفج ريت، داي 2 امبريو، داي 3 امبريو، بلاس تو سيست، سكسسفول بايوبسي ريت، بلاس تو سيست كرايو سرفايفل ريت، امبلانتيشن ريت. اوكي؟ This is another paper published in Fertility Sterility 2020 emphasized that KPIs must be measurable, reproducible, appropriate to define effectiveness and safety of care. They divided laboratory KPIs into 3 groups. First is the structure of IVF lab. Second is the process-related key performance indicator, and the third group is outcome.
Sorry, doctor, I have to interrupt you again. I think time is
just
finished already.
Less than minute.
Could we go to the conclusion, please?
Less than minute.
Can we go to conclusion?
So, which key performance indicators is paper? And this their diagram, structure indicator about putting your apparatus and the movement inside the lab, how many incidents have been occurred in the lab, and the process indicator and the outcome indicator. This. Okay. After you measure your performance, you have to see if you have an improvement. Okay, you have to modify your warning level and your maintenance. Okay. عندنا في control warning limits و control limits في الشارت ده عشان ما فيش وقت بقى. Okay, this paper published in 2022. And Professor Dr. Hassan Salam was one of its contributor. He is famous, I think all of you know him in Egypt. And they take a closer look at the key performance indicator in assisted reproductive technology, a guide for reproductive professional. Okay, this is the last slide. This is a relatively new total quality improvement. We will move from the term of key performance indicator to total quality improvement, not total quality management system. This is a relatively new approach to quality management system in assisted reproduction clinics and aim to encompass all of clinic activity, ensuring optimal performance, not just through pregnancy rate, but also in patient satisfaction and financial performance. And thank you.
Thank you, doctor.
Thank you very much, Dr. Yasser Yunus, for that intriguing and amusing presentation. Our next speaker will be Dr. Nazik Omar from Sudan. She did clinical embryology and reproductive medicine training in George August University in Germany. A holder of master's degree in reproductive medicine, she has over 20 years of experience and is one of the pioneers in Sudan in her field. She is the president of the Sudanese Clinical Embryology Society and the president of the Clinical Embryology Department in Sudan National Council for Medical and Health Professionals. She is the IVF unit director in Al-Atrab and Injab Fertility Center in Khartoum and is the manager of the same center. She'll be talking about the definition and management of recurrent implantation failure. Could you all give us a warm welcome, please?
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you very much for giving me this opportunity to take part in the first international Noor الحياة fertility conference. This is my first time in Libya. I'm very happy and I'm very impressed about everything. God bless you and good luck. My presentation is about recurrent implantation failure. Recurrent implantation failure is an uncommon, imprecisely defined clinical disorder characterized by failure to achieve pregnancy after repeated embryo transfers. The diverse etiologies and incomplete understanding of recurrent implantation failure provide significant diagnostic and therapeutic challenges to patients and providers. It is known that up to 70% of embryos developed via natural conception or IVF treatment are lost before birth, usually within the first 3 months of pregnancy, and most of these even before implantation. I don't know why it's... ISHRI defines recurrent implantation failure as failure to achieve pregnancy following several cycles of IVF where 3 good quality embryos have been transferred, and also it refers to failure to achieve a clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycles in a woman under the age of 40 years. There is a lot of risk factors contributing to this problem, and the most important among them are maternal age, body mass index, smoking, and stress. The pathophysiological mechanism of recurrent implantation failure is not quite clear until now, but there is a lot of factors contributing regarding the gametes, the embryos, the endometrium, and other factors. Considering the gametes, the oocyte, this problem is usually related to poor responder and a high proportion of immature oocyte, which is reduced fertilization rate and low embryo utilization rate. It's also often associated with low antral follicle counts, high FSH, and low anti-molecular hormone. It's quite known that age-related decline in oocyte quality is associated with increased chromosomal non-disjunction, resulting in aneuploid embryos, decrease in mitochondrial membrane potential, and increase in mitochondrial DNA damage. Considering the sperm DNA damage and advanced paternal age contributes to the problem. Considering the embryo, abnormal embryo development can be due to chromosomal abnormalities of male or female partners, such as translocations, inversions, deletions, increased incidence of sperm chromosomal abnormalities, increased zona thickness, which lead to decreased implantation rate, embryonic stress, culture media and incubation, and aneuploidy. I don't know why it's, sorry. The genetic factors, translocations, mosaicism, inversions, and deletions are more frequent in recurrent implantation failure patients than the general population, and yet the prevalence is only about 2%. The most common abnormality is translocation. Aneuploidy, it was found that aneuploidy in 1 or 2 chromosomes is not considered a significant cause of recurrent implantation. It should be involving 3 or more chromosomes. Parental chromosomal anomalies. It's known that individuals with balanced translocations often produce gametes with chromosomal aberration, which may in turn result in various forms of reproductive failure, ranging from defective gametogenesis to recurrent spontaneous miscarriages. The most important factor contributing to the problem of recurrent implantation failure is endometrium in many aspects. Considering immunological, there is a lot of observation related to natural killer cells, the ratio between T helper 1 and T helper 2, and the presence of tumor necrosis factor alpha levels. There is relative agreement that elevated levels of T helper 1 cells are associated with rejection of embryos, whereas elevated T helper 2 levels associated with pregnancy. A lot of theories also including antiphospholipid syndrome, hereditary thrombophilia, infection, and endometritis. Anatomical uterine and tubal factors, including polyps, myomas, hydrosalpinx, adhesions. It was found that polyps and myomas can cause a distortion of the endometrial cavity, and adhesions can prevent attachment of the embryo to the luminal surface. Hydrosalpinx also can cause deprivation of proper embryo development due to the fluid's lack of nutrients and energy. In addition, the fluid can negatively impact the endometrial receptivity and also can physically flush the embryo, preventing the implantation. Congenital uterine anomalies, including septate uterus and bicornuate uterus. It was found that septate uterus is contributing to the problem of recurrent implantation failure, while bicornuate uterus is more related to the mid-trimester pregnancy loss and preterm birth. Thin endometrium. Defective endometrium can be due to previous endometrial trauma, prolonged use of oral contraceptive pills, impaired uterine blood flow. From a thickness of 9 millimeter to 16 millimeter, chance of pregnancy increases from 53% to 77%. How to investigate for patient with recurrent implantation failure? Considering intrauterine pathology, we can apply transvaginal scan, MRI, saline infusion sonography, hysterosalpingo contrast sonography, and hysteroscopy to find out or to rule out polyps, myomas, and adhesions. We can apply hysterosalpingogram to detect hydrosalpinx. Sorry, I don't know why this. And for the endometrial biopsy pathology, we can do endometrial biopsy to detect chronic endometritis and uterine natural killer cells. We can also apply a blood test for antiphospholipid syndrome and thrombophilia. Considering embryonic factor to investigate for patient for recurrent implantation failure, we can detect ovarian reserve test by antral follicle count, FSH level, and AMH level, sperm DNA fragmentation test. Management of recurrent implantation failure. Since it is a complicated problem, a multidisciplinary approach should be adopted in the management of a couple with recurrent implantation failure. It should involve not only an experienced fertility specialist, but also a senior embryologist, and where appropriate, a reproductive surgeon or a counselor. The first line of management of recurrent implantation failure, according to the recent ISHRI guidelines, is the lifestyle changes. In addition to a review of investigations and treatment to date, clinicians should discuss and advise to a lifestyle changes to couple with recurrent implantation failure. Smoking women should be advised to stop, as there is an evidence that smoking is associated with an increased gonadotrophy requirements for ovarian stimulation, fewer oocyte retrieved, higher number of council cycle and lower implantation rates, and more cycle with failed fertilization. Also, male partners of women with recurrent implantation failure is advised to abstain for smoking due to its adverse effect on sperm counts and motility, and increased abnormal sperm morphology problem and sperm DNA damage. Improving embryo quality and selection. There is a lot of theories regarding this. One of them is blastocyst transfer and pre-implantation genetic testing. The value of pre-implantation genetic testing in recurrent implantation failure is controversial. There is no evidence to suggest that the embryos produced by women with recurrent implantation failure are more likely to be abnormal. The frequency of aneuploidy in this group is 67% compared to the group without the problem, which is 64%. Therapeutic interventions for recurrent implantation failure. There is a lot of suggestion regarding optimal IVF treatment in embryo factors, blastocyst transfer instead of cleavage stage transfer, frozen transfer instead of fresh transfer, and assisted laser hatching. It's also recommended to do the transfer under an ultrasound guide using soft transfer catheter and do aspiration of cervical mucus. Considering ovulation induction protocol, this area of discussion really has a lot of wide range of different opinions by using agonist versus antagonist, using agonist and antagonist, or none of them, or both of them. This area really calls for larger trials. There is a suggestion also and discussion about progesterone support. It was found that there is no difference comparing different types of progesterone, and heparin usage as anti-thrombotic agents has been evaluated, and in recurrent implantation failure patient, thought there is not yet evidence to recommend its use to improve the pregnancy outcomes. A lot of talk also about immunotherapy and antibiotic for infection, and a lot of suggestion in endometrial intervention like hysteroscopy scratching, PRP, granulocyte colonally stimulating factor. As I said before, recurrent implantation failure is a complicated problem, and until now there is no clear understanding of the pathophysiological cause of this problem, so there is no clear protocol for it. But the recent ISHRI guidelines suggest that there is 3 important factors we should spot on it. It's the endometrium, the genetic factor, and the changing of the lifestyle. Thank you very much.
Thank you. That was Dr. Nazik Omar. Our next speaker is Professor Suad Uthman from Libya. She's a professor of obstetrics and gynecology. She is also a fellow, the Royal College of Obstetrics and Gynecology, London. In addition to that, she holds a position of medical director at the Al-Masarra Clinic, Tripoli. She will be talking about ovarian drilling, do's and not to do's. Could you all give us a warm welcome, please?
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. My lecture today is about ovarian drilling. Okay. The aim of the lecture is to evaluate the role of laparoscopic ovarian drilling in management of BCOs. Different pre, intra, and post-operative aspects will be dealt in this lecture. Polycystic ovarian syndrome is the most common endocrinopathy encountered in young female population. It is the most common cause of anovulatory infertility. Clomiphene citrate remains the first-line therapy for anovulatory patients with BCOs. Ovulation can be anticipated in 80 to 85% of cycles, half of which will result in a pregnancy. So clomiphene citrate is the first line of management in such patients. Unfortunately, 15 to 40% of anovulatory subjects are resistant to standard clomiphene citrate regimen. Then, this group of women will be shifted from the first line to the second line. The second line, either laparoscopic ovarian drilling or gonadotrophin. Evolution of surgical management of BCOs, laparoscopic ovarian drilling using diathermy needle point electrode was started in 1984 to replace wedge resection of the ovaries, which was the main therapeutic approach for a long time, and it has been abandoned because of the great risk of adhesions and reduction in the ovarian function. Since then, many modules or modalities of ovarian drilling has been came to the surface and has been tried. Now, where did the idea of ovarian drilling came from? The idea of needle drilling came to mind through the observation of improved ovarian performance in patients with BCO after previous follicular aspiration for IVF trials. None of the participants in that trial conceived in the aspiration cycle. However, the response to ovulation induction was improved in subsequent cycles. Therefore, this is the effect of the aspiration which was carried out in the previous cycle. Laparoscopic ovarian drilling. What is the mechanism of action? And what are the procedure principles? The mechanism of action is not understood, but there is intra-ovarian mechanism, destruction of the androgen-producing stroma, drainage of follicles with high androgen and inhibin content, alteration in the level of various intra-ovarian growth factor are supposed to be the intra-ovarian mechanism. Now, in addition to the intra-ovarian mechanism, there is central mechanism. Markedly reduced LH amplitudes with no change in pulse frequency, and markedly attenuated response to gonadotrophin releasing hormone and challenge test that is after ovarian drilling. والله ضغطت. Now, looking at this graph, FSH level in the control group, BCOs before and after laparoscopic ovarian drilling, it's quite clear that BCOs after the drilling, their FSH level goes up compared with the control, compared with the BCO. Now, what's about LH level? LH level goes down in BCOs after laparoscopic ovarian drilling. So the change in LH FSH levels after ovarian drilling is the key for the function of the ovarian drilling. Now, LH FSH ratio is reduced after laparoscopic ovarian drilling. Total testosterone level after ovarian drilling goes down. So these changes in the hormonal levels is believed to be the reason for the success after ovarian drilling in getting ovulation in such patients. And this is another example. Now, so summary to the previous slides, continuation of follicle growth in subsequent cycles after ovarian surgery occurs in an environment with less androgen, lower LH, and FSH levels compared with pre-treatment level. Resistant index changes after ovarian drilling. Pulsatility index changes after ovarian drilling. These two slides shows that blood flow to the ovaries is increased after ovarian drilling. This will enhance more delivery of gonadotrophin to the ovaries. Now, what's about the ovarian volume? Doing ovarian drilling is associated with reduction in the ovarian volume. We have to be careful about this. So what are the indications for laparoscopic ovarian drilling? It's quite clear. Clomiphene citrate-resistant BCOs, persistent high-level LH, intolerable side effect of drugs as clomiphene citrate or human menopausal gonadotrophin. If there are other indications for laparoscopy and the patient has polycystic ovarian syndrome, then we can go for ovarian drilling. No available or feasible monitoring. A patient lives far away from a place where monitoring can be done for ovulation induction, then this method is quite suitable for her. سؤال: Is ovarian drilling a useful procedure? الجواب: spontaneous menstruation occurred in 80% of the patients who underwent laparoscopic ovarian drilling. More important, ovulation occurred in 62% of the cases. So these figures are encouraging to go for laparoscopic ovarian drilling for selected patients of PCOS. Now, what are the predictors of success? This is a list of the predictors of success. It will help the clinician to counsel the patient and to give her the success rate and to go for laparoscopic ovarian drilling or to shift to another modality of treatment. So it's very important to go through this list prior to any procedure. Now, what's about anti-Mullerian hormone? High levels of anti-Mullerian hormone is associated with low level of success with laparoscopic ovarian drilling. Free androgen. High androgen levels prior to treatment would be associated with low success rates. Body mass index. high body mass index is associated with low success rate of laparoscopic ovarian drilling. Now, it's very important to compare between the two items of step 2 in induction of ovulation. Item 1, laparoscopic ovarian drilling. Item 2, gonadotrophin ovulation induction therapy. It has been shown that multiple pregnancy is less among women treated with laparoscopic ovarian drilling. And the ovulation rate is the same, but the risk of multiple pregnancy is less among laparoscopic ovarian drilling group. Money-wise, laparoscopic ovarian drilling is less costly than induction of ovulation using gonadotrophin hormones. Now, what's about abortion? It has been shown that abortion rate is less likely to occur following laparoscopic ovarian drilling if the patients got pregnant compared with pregnancy rate or abortion rate in women given gonadotrophin hormones for induction of ovulation. Now, what is the advantage? It is a single action, no intense monitoring, less expensive than gonadotrophin, monofollicular ovulation, no risk of multiple pregnancy, less risk of ovarian hyperstimulation syndrome, and less abortion rate. Long-standing effect could last 1 year or more. Now, what's about the guidelines? Are they with or are they against? Nice guideline, women with clomiphen-resistant PCOS may be offered LOD because it is as effective as gonadotrophin treatment and is not associated with the risk of multiple pregnancy. Now, this is a consensus, says alternative to gonadotrophin for clomiphen-resistant anovulatory PCOS, LOD achieves unifollicular ovulation, reduced risk of ovarian hyperstimulation or multiple pregnancy, intensive follicular monitoring not required, reduced direct and indirect cost. RCOG, laparoscopic ovarian drilling with either diathermy or laser is an effective treatment for anovulation in women with clomiphen-resistant PCOS. The same with the Society of Obstetrics and Gynecology in Canada. Now, we come to the complications. There is no procedure without complications. Complications related to anesthesia, laparoscopy procedures, and related to drilling itself. To drilling itself, adhesion formation, decreased ovarian reserve, ovarian atrophy, and risk of premature ovarian failure. So, number one, the complication of ovarian drilling, adhesion formation. The rate reported between 0 to 70%, there is such variation. Great diversity of rate of adhesion may be due to variation in the technique, partly on interpretation of findings on second laparoscopic look. Adhesion formation is more with laser than electrocoagulation, so it's better to use electrocoagulation. Adhesive barriers don't reduce its incidence. Abdominal lavage helps in reducing adhesions, and it's very important. Use of insulated needle help to reduce adhesions. Then do you do the drilling one ovary or both ovaries? Doing in one ovary being claimed to reduce the risk of and the rate of adhesions. We finish with adhesion formation, decrease ovarian reserve. Is ovarian reserve diminished after LOD? BCOs had significantly greater ovarian reserve than the age-matched controls having normal ovulatory menstruation. LOD, if applied, normalizes the exaggerated ovarian morphological and endocrinological properties. معناها that means LOD normalizes the ovarian function rather than to reduce the ovarian reserve. The other complication, or ovarian atrophy and premature ovarian failure, this is the result of excessive drilling. You don't need to do excessive drilling. You have to do it in a tailored way. There's another complication, epithelial ovarian tumor. There is a theoretical concern that ovarian drilling may increase the incidence of epithelial tumor, but there is no long-term follow-up to evaluate such association. Now, surgical technique. To reduce the complications I've already discussed, we have to do it in a proper way, in well-standardized way. Now, procedure principles, preoperative requirement. It has to be a case of BCO, clomiphene resistant, normal prolactin level or treated, inability to undergo gonadotrophin therapy, of course, normal endometrial cavity with patent tubes, and the partner has to have normal semen analysis. Now, we counsel the patient. She's today for laparoscopic ovarian drilling. In theater, we have to use unipolar. Current is advised in a cutting mode to minimize thermal damage. The power is activated just before touching the ovary. The needle is used as a special needle. Anti-mesenteric border of the ovary should be grasped, and the drilling should be carried out in perpendicular to the ovary. The number of cauterization points depends on the ovarian volume from 4 to 10, but I will come to that again. Su'al, the question, do we do drilling for one ovary or for both? Now, 8 eligible trials were analyzed, and they found no significant difference in the rate of ovulation, a clinical pregnancy, or live birth if drilling was applied to one ovary or both ovaries. Now, what's about miscarriage? There is no difference. Reduction in MH was comparable, and a significantly higher antral follicle was found with those adjusted ovarian drilling. Therefore, unilateral ovarian drilling gives the same result as bilateral. Therefore, some authors, they encourage to do unilateral than bilateral to reduce the risk of adhesions. Now, the amount of energy should be calculated as power, duration, and number of puncture. The amount of energy each ovary received. Now, how many punctures? 4, 5, 6, 10 more. Too little is insufficient. Too much is harmful. We have to make an agreement about the number of puncture. It has been shown that 4 puncture will be the number needed to get ovulation and to get the parameters needed to correct the patient's situation. Overall, there في اتفاق consensus. Rule 4, 40 watt, 4 seconds, 4 puncture points per ovary will give the lowest effective dose recommended. There's another program saying tailoring the number of punctures according to the ovarian volume. You estimate the ovarian volume, and according to that, you do the number of punctures. But it is agreeable that you do 4 punctures with the previous, what I said, it will give you the proper dose of thermal injury. Now, do we do laser or electrocautery? I've already said that, but I would like to repeat it. يا إما comparing the two together, laser especially, CO2 may be associated with a high risk of adhesion formation. Therefore, electrocautery is superior. And this slide shows clearly that pregnancy rates, spontaneous ovulation is more likely to be when electrocoagulation is applied compared with laser. Now, another modalities have been in market or had been used, for example, harmonic scalpel. Now, I would like to come to this. Please, 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 follow this. Never drill unless indicated. There are other techniques, for example, laparoscopic ovarian multi-needle intervention. In this modality, this is a special instrument. We use this instrument to crush the ovary without using any energy. Crushing the ovary itself had been claimed to do some sort of ovarian drilling. It has been used and has proven its efficacy. لا عودوا لي في هالشيء هذا اللي صاير هذا شوي بس أنا حنمشي هذا. I'm not going to go through the other modalities. Take work message. I didn't like to say take home message. LOD is an attractive alternative to gonadotropin stimulation in clomiphene citrate-resistant cases. Proper selection of cases will help in greater cumulative success rate and help in predicting response. Despite all disadvantage, it is a surgical procedure which has its own risks. So we have to be careful about the risk, and we have to do our effort to reduce such risk. So don't take home message, take work message, because life tip, leave work at work. When you come tomorrow to your work, the message is in front of your desk. Take a bouquet.
Thank you, Professor Suad Uthman.
Take a bouquet of flowers to your home rather than a message of your work. You've seen it. Just to say thank you from me and from my granddaughter. Thank you very much.
Thank you, Professor Suad Uthman, for that intriguing and informative session. Now we move on to Dr. Ines Yahya from Libya. She currently holds an Arab board in obstetrics and gynecology. She's also a specialist in obstetrics and gynecology. She's the former head of obstetric and gynecology unit in Tobruk Hospital. She's a former obstetric and gynecology syndicate head. She's also the former medical school at the University of Tobruk Dean.
Good afternoon. Thank you to give me a chance for introduce my research paper for us. Myoanisitol, this is a new challenge in the treatment of polycystic ovary with infertility. We know the polycystic ovarian syndrome is a common reproductive condition associated with chronic anovulation and subfertility and it is commonly show oligomenorrhea, regular menstrual cycle, and increase the androgen level, and atypical ovarian ultrasound. Insulin resistant in association with also luteinizing hormone increase and production of androgen in TK cells. Therefore, the treatment with insulin sensitizing agent like anisole and triglyceride or metformin in a woman with polycystic ovarian syndrome may lead to continuation of spontaneous ovulation. Myoanisitol it inhibits an duodenal absorption of the glucose and reduce the blood glucose rise, and suggesting existence of competitive affinity for the same transporter system. Glucose significantly counteract the cellular uptake of anisitol and may induce myoanisitol depletion. Metformin also an insulin sensitizer that lower the fasting level of the plasma insulin and decrease the hepatic glucose production, and it lower the theca cell androgen synthesis in vitro and has a positive effect on the metabolic disturbance and bleeding disorders with polycystic ovarian syndrome. Our patient material and method done in Tobruk Medical Center from January 2019 to 2022. Total number was 600 cases. Age ranged from 18 to 38 years with polycystic ovarian syndrome. And the patient was given written informed consent before sharing the study. After we took the consent, we start our research. All the patients are investigated for fasting insulin and glucose level to confirm the insulin resistant by increasing both insulin and glucose level. So we take the patient with insulin resistant in our study. All the patients informed about possible results, our study, and half of them refuse using myoanisitol for financial causes. Patient was randomly distributed into two groups. Group 1, 300, which with myoanisitol 2,000 milligram daily by taking 2 tablets after breakfast and after the lunch, and another, after the dinner, and another 1 tablet with metformin 850 milligram after the lunch. The second group, also 300, in which take metformin only 850. All the patients were followed by ultrasound to see the progress of the ovulation and the clinical follow-up. The result was accordingly mean age and pre-study glucose level and pre-insulin level. The first comparison was in the serum glucose level. In the first group, it was about response sensitivity 57. In the second group, 42. About the serum insulin level, in the first group, about 52. In the second group, about 47. About the acne, 60% respond with the mix in the group 1 and 39 in the group 2. Hirsutism, it was not well responding responding 58% with the group 1 and 41 with the group 2. And body weight, there was reduction 61% with the group 1 and 38 with the group 2. And about the menstrual regularity, 54% with the group 1 and 45 with the group 2. And follicular diameter of folliculometry, it was the response 60% with the group 1 and 39% with the group 2. And pregnancy rate, it was 61% with the group 1 and 38% with the group 2. So, the beneficial effect of myoanisitol, and it is an active form of dichloroanisitol, it was formed with endogenous from 40:1, have improving the metabolic profile of the polycystic ovarian syndrome, fasting serum insulin, and on HOMA index. Moreover, significant reduction in the body weight, significant reduction in the hyperandrogenic features, and reduction of the testosterone, and increase in the sex hormone binding globulin. Metformin, the most common insulin sensitizing agent for polycystic ovarian syndrome, and significantly induces nausea and abdominal diarrhea, thereby the myoanisitol reducing. The patient complained myoanisitol is generally well tolerated. The effect of myoanisitol in the serum triglyceride and very low density lipoprotein and cholesterol level, and a quantitative insulin sensitivity check index was significantly higher compared with metformin. Myoanisitol and metformin in combination could act in additive or synergistic way, allowing the use of reducing doses of metformin in the patient in tolerance to the normal therapeutic administration of metformin. There is two study about, mini study, but to take two example, like Minozzi et al. Shows patient with mild and moderate hirsutism, administration 2 gram myoanisitol twice for 6 weeks lead to significant decrease in the sensitivity of the hirsutism and levels of total androgen, FSH, LH, LDL, and cholesterol. Another study, Raffon reported 65% of myoanisitol treated the patient restored spontaneous ovulation activity compared to 50% of the metformin treated patient. Combination of myoanisitol and metformin show a better effect on the menstrual cycle than the metformin alone, despite the similar effect of both treatment on weight, body mass index, waist, hip circumference. So our conclusion, our results show that use of myoanisitol and metformin is an useful treatment for polycystic ovarian syndrome with infertility, with improvement of laboratory, clinical, and ovulation with subsequent pregnancy. Definitely, we are attentive that further larger researches are compulsory as a meta-analysis in Libya. Thank you.
Thank you. That was Dr. Ines Yahya. We now open the floor for discussion of the second session. If anybody has a question or a remark, could they please put their hands up? One of the microphone assistants will come to your aid. The chairmans will be monitoring the discussion.
دكتور محمد المحيشي.
Sorry, Dr. Yahya. Thanks very much for your very nice.
سلام عليكم مشتاقين بس. Sorry. You
go first.
Because yeah, carry on.
Sorry, he brought the one first here. I didn't see. Let him start first.
No, carry on. You are my guest.
Yahya, thank you very much for your very informative talk on myoinositol. In South Africa, this has been used with great success, the combination of myoinositol and metformin. But in much higher doses, and I would like your comment on it. Up to 5 grams per day proved to be very good, but now the medical board is trying to show that they shouldn't use more than 1 gram. Could you comment on that?
850 dose, but we can increase. But in this, huh? Myoanisitol 2,000. 500 within the tablet, receive 2 by 2. To morning to evening time. Okay?
First, I myself just only comment. I agree, not more than 1,000. Not too much for myoanisitol. But I want to thank Dr. Yasser for his nice lecture, and it should be a copy to everyone using IVF or he has a center, because this is the guideline for any center. But if you have a time, maybe you make some copies and put it tomorrow here to take it, because that's what should be. Because really, I've seen, especially in our area, not Libya only, in Arab area, just only no control. This is one. No, another. I want only comment. I don't know why Professor Suad not mentioning the letrozole, which is the drug of choice in polycystic. We are no more resistant and so on. So, if we are not doing a drilling, we do letrozole. Give letrozole, and the drilling, it has to be according to the size, and maybe she got it from studies. But for me, not more than 3. And some even 1 or 2, depend on the size. And thank you. Sorry.
أنا طبعا أشكر حضرتك على الكومنت ده. هو فعلا موضوع إن يبقى عندنا كي بيرفورمانس انديكيتور في كل المراكز بتاعتنا، ده حاجة مهمة جدا. أنا سعيد جدا إن أنا أدي لحضراتكم كل الريفرنس اللي أنا جبت منها المحاضرة الجميلة دي، علاوة على إن الحمد لله أنا كواليتي إكسبرت واخد دبلوم في الكواليتي إكسبرت من إسليسكا باريس. فكل البرنسبلز بتاعت الكواليتي لو أي حد من حضراتكم want to implement الكواليتي مانجمنت سيستم، انا هكون هابي جدا ان انا يعني اساعد السنتر في الموضوع ده. والف شكر لكم. شكرا. كان
طبعا for دكتورة سعاد شكرا. I quite agree with you. The indication of laparoscopic drilling is declining and restricted, and the most important for evaluation is the live birth rate. If we go to the last Cochrane systematic review, comparing between medical treatment of polycystic ovary syndrome and the laparoscopic drilling, and the conclusion was surprising. With laparoscopic ovarian drilling, the live birth rate is less, decreased, and this is the most important. Laparoscopic ovarian drilling not indicated at all for the obese, not to be repeated, not a treatment of Hirschism. And we should give it in, as you mentioned, in the proper or the appropriate indication. For Doctora, yes, shukran, a very nice work, but you didn't mention to us, what is your cut-off level for diagnosis of insulin resistance? Yes. انت قلتي بانك انت استخدمتي الفاستنج انسولين واستخدمتي الهوما واستخدمتي ده، لكن ما قلتلناش على الكات اوف ليفل بتاعتهم. شخص
fasting insulin more than 30. We take the limit, yes. As a fasting, yes. اساس انه resistant.
And the most important or more reliable is the fasting insulin ratio, not the fasting insulin, right? Yes. But did you use it or not? No, shukran.
Any more questions?
اتفضلي دكتور. تفضلي دكتورة.
Thank you, Dr. Ines, for the nice presentation. I want to ask, why did you add metformin for the install group? why you didn't use just install?
Yes, my question also. Yeah.
البي سي او طبعا انا يعني حاولت اني نستعمل بانيستول يعني الانستول الون، فكان الريسبونس متاعي يعني قبل ما نبدا ستادي متاعي كان الريسبونس نشوف الفيدباك متاعي مش ويل، فكان البيشنت اوريدي هي على الميتفورمين. دكتوره لو نضيفوا لو نقدر نكمل على الميتفورمين كملي، يعني ما دام هي السايد افكت نتاعها توليريتد باي ذا بيشنت وتقولي دكتوره نقدر ناخذ حبه، فحسيت يعني حتى لما شفت اكثر يعني طلعت عليه ميني بيبرز I find sorry when I follow the patient before the study, the patient was using metformin and try to change to my inositol. Then the patient asked me, Doctora, please, I can continue with metformin? I inform, okay, continue. I find that my feedback is better than start my inositol alone. When I searching about this, I find about 6 papers. They add metformin to my inositol. I start this from this study within 3 years. I have good feedback in Toporek in polycystic ovarian syndrome by this result.
Sorry, Dr. Ines. I think it will be better if you choose patient not starting any insulin sensitizer. I mean, take patient 3 arms. One will start metformin, one inositol, one both. So you have 3 arms and don't taking any insulin sensitizer before, so that you have a good result.
Next, we will add another only by my inositol to make the comparison by the 3.
I mean, the patient is not already on insulin sensitizer. You will start with her with the basic.
Pure. إن شاء الله.
العفو. الكلام في سؤال من عميد طب المنوفية.
الثلاثة توكس اللي اتقالوا بأمانة كويسين جدا. واحد بيعتبر بالانس اللي هو الكي بيرفورمانس، أو لو خليناها سيمبل شوية هاو كان يو امبروف زي ما حكى الدكتور ياسر الريزلتس ان اي في اف لابس او بوجه عام. لازم نعتقد حاجه مهمه قوي وهو قالها بس يعني ما تعملش ستريس عليه، ان the only success for the patient will interest the only success for the patient yes the only success for the patient is the take home baby. This is number one. As regards the talk of Professor Suad and Dr. Ines, both dealing with polycystic ovarian syndrome patient. First of all, we have to differentiate between infertile polycystic وadolescent polycystic female. في الانفرتايل مفهوم النظام، واشكر الدكتور المحيشي انه نبهنا ان الميتفورمين ما بقاش الفيرست دراج اوف تشويز، لكن دلوقتي البالانس او التشويز بين الدريلينج اند للتريزول. اذا لو كانت ادوليسنت evidence based the use of oral contraceptive pill is the clue. وفي الاثنين اللي هي infertile او married والادوليسنت we must to modulate the lifestyle, obese, weight reduction ولifestyle modification. This is number one. لان هو ده هيضيع مجموعه كبيره قوي زي ما حكى الدكتور بكر من مش هتحتاج حاجه. وكلنا في البراكتس بنلمس هذا ان الويت ريدكشن والادفايس والستريس عليه بيكمل. الاوبيز دكتور بكر حكى كلمه بس هي ما بتتقالش كده، ان obesity is not an indication for ovarian drilling، ولكن reduction of weight is a must even ان احنا نعمل لها سليف لو فيلد كل الموداليتيز الثانيه. حقيقه انا بهني القائمين على امر المؤتمر، موضوعات ويل سيلكتد والتوكس سيمبل بسيطة، يعني أكلات قد لا تبدو دسمة ولكنها مشبعة ومفيدة. Thank you for all.
For Dr. Nazik, the recurrent implantation failure, I want to refer you to the HFEA. They put a clear, sharp, the red, yellow, and green. One of the green is to check in recurrent implantation failure for TSH and thyroid peroxidase antibodies. And one of the yellow is the vitamin D checked. For my own, I am checking the vitamin D routinely in recurrent implantation failure because the prevalence is high, and especially in our community. Thanks, Dr. Nazik.
Regarding the laparoscopic surgical intervention for ovaries, now I think PCO and endometriosis completely stopped. Nobody used laparoscopic diathermy for PCO. All over the world, I think all centers are stopped to do drilling for the ovaries because you may cut off the ovaries. I have some patients come to me after the ovarian drilling. The image was very good. After that, becomes zero. So you have to stop. You damage the ovaries. You know that. So nobody can use it anymore.
Thank you for the feedback, doctor. And a closing remark to Dr. Saad.
The management BCO is tailored according to the presentation and to the age group. Adolescent BCOs, their management differs from adult BCOs. A lady presented with infertility, her management differs from a lady presented with hirsutism. The cornerstone of management of BCOs, lifestyle, modification of lifestyle. Then, according to the special presentation, we have to deal with laparoscopic ovarian drilling should be reserved to clomiphene-resistant cases. Then, if you would like to use letrozole, use letrozole. If they are resistant to letrozole, then you go for laparoscopic ovarian drill. If you do it and you follow the rule of 4, the patient will not lose her ovaries. And before you do it, you have to read the list of predictors of success. Does she have a high success rate or a lower success rate if you offer her laparoscopic ovarian drill? Thank you.
Thank you, doctor. And there is a surgical opinion that I think we would be interested to hear. So.
أنا نبي بس كلمة واحدة. In adolescent, no interference, please. Only lifestyle, full stop. She has to do so. So I see in patient is acceptantly resistant to this, but a lifestyle. Well, we are a clinician, we have to observe also our work. For letrozole, it is important, Saad, to put it in your mind, but I am agreed to do puncture, and I said maximum 3, but there is indication for laparoscopic drilling. Nothing in medicine say no. There are indications with us.
Thank you for all.
There is another surgical input that we would like to hear.
Mohammed Abu
Yes.
Dabous. Surgical point of view of the ovarian drilling, we cannot say there is no rule of ovarian drilling nowadays. We have here maybe 80% of the audience, they are young doctors, so it's we have to stick in our guidelines. Ovarian drilling, rule of 4, still up to date is there. So it's an option for PCO. Maybe it's not the first line of treatment or management, but it's the line, or maybe the second or third in resistance in patient special circumstances that patients not closer to our clinic, coming regularly by induction of ovulation by using letrozole or something like this. But ovarian drilling, if we are stuck to the rule of 4, using 40 watt, 4 second, proper instrument, expert surgeon, we have promised result. Even after the drilling, starting induction of ovulation by letrozole, reach to the 70% of the cases coming pregnant. So that's why ovarian drilling up to date is an management. Thank you.
Thank you. We hereby conclude the session. We thank all the participants and all the prominent professors who provided very impressive feedback. Thank you to all.
Thank you.
Thank you. That brings us to the end of session number 2. Now we would like to commence to start session number 3. Continuing our sessions, it's going to be talking about surgery. Without further ado, I would like to invite the chairman, Professor Yusuf Gadmour, Professor Muna Al-Gubbi, Professor Muhammad Hamouda, Dr. Yasser Yunus to the stage, please. Before we commence with our session, the chairman would like to make a comment.
Mike, okay. Just before we start session endoscopic surgery, we would like to introduce Prof. Ralph, who will commence, important comments as been asked by the chairman, Dr. Mheshi, to give him a chance, 5 minutes to commence about the use of antioxidant in male infertility, how safe it is. Would you come, please?
Yeah, the use of antioxidants is actually very common because in everybody's mouth is oxidative stress is dangerous. However, we need to understand that a small little amount of reactive oxygen species, which is these highly reactive oxygen derivatives, are physiologically essential to actually trigger physiological reactions, without which the fertilization process and the maturation of sperm and maturation of oocytes will not be possible. Just an example. Capacitation narcosome reaction are triggered by a small little amount of reactive oxygen species. If you exceed a certain amount of antioxidants in the body, so actually meaning that the body is coming out of balance, out of equilibrium, when you push the system in the body into the direction of reductive stress. And reductive stress has been shown to be as harmful as oxidative stress. So it is essential that we check the patient before we treat with antioxidants. And an indiscriminate use of antioxidants can be dangerous. One example, in South Africa, I had a couple where I was approached by the gynecologists. Henkel, we have a patient with recurrent pregnancy failure after ICSI. Do man your DNA test? I did that test, it was still inconclusive,
and when I consulted with the patient. As a result, the patient told me, we are so healthy. My husband is cycling, point 1, which is a problem for the man. And point 2, we are taking all the antioxidants. And when I asked her, what are you taking when she presented herself, me with such a long list what she was taking and what her husband was taking. When I was thinking, this cannot be right. And I advised, stop it immediately, both of you. After 3 months, she fell pregnant spontaneously. That is just a case report. What I have seen, we see that an excessive use of antioxidants can be problematic and even dangerous. So please keep that in mind. Check the patient before you treat the patient with antioxidants, and bear in mind that patients are listening to any kind of advert in the newspaper or in the TV or wherever, and friends take this, take that, and they take anything to fall pregnant because they are in desperate need. They want desperately the baby. So they do anything and take, and that is in the end too much. Remember, too much of a good thing is a bad thing. Thank you very much.
Thank you.
هو أهمية الموضوع اللجنة العلمية رأت أنها حتعطوه تشانس بكرة الدكتور بروف شارف 10 minutes حيشرح لكم الأنتي أوكسيدنت في الميل شنو الدينجر نتاعها لما تعطيهن أوفر. في ناس يستعملوا 2-3 تايبس وأنتي أوكسيدنت شفناهم في البراكس ديلي ودوز عالية. شركات تقول لي أعطي 2/3 2/4 حاجات رهيبة راه عندهم سايد افكت كبير على الميل. فبكره حيشرحوا في جهاز جديد مصنعينه في العالم في اليو كي انه كيف تحسب الانتي اوكسيدنت في الميل وشنو الدوز اللي تعطيها وهاو تو كنترول الدوز نتاعك بكره الصبح ان شاء الله. شكرا.
Thank you. Thank you, Dr. Mohammed Hamoud, and thank you, Professor Ralph Henkel. Our first keynote speaker for this session will be Professor Abdelhafid Abu Dhair. Professor Abdelhafid Abu Dhair is a consultant obstetric and gynecology at the Yashafin Clinic. He's also a founder of Libya Gynae. He's a former head of the Center of Disease Control. He's also a former professor at the University of Tripoli. He's also a member of the Global Support Assessment Tool for the World Scout Movement. His topic will be hysterectomy and infertility. Could you please join me to the stage? Warm welcome for Doctor.
السلام عليكم. Gaila. Okay. Thank you very much for the organizing committee for this big event, and thank you very much for the chairman and the co-chairmen for this sitting. I'm going to speak about the role of hysteroscopy in infertility. It's not for the hysteroscopist, but for the people who still they have got a doubt about the role of hysteroscopy in treating patients who have got infertility. Before we start, I want to comment about the previous session. There was a lot of discussion, and that's a healthy one. But do for the patient what you think is for her best interest, based on a scientific based evidence, and what you are good in doing that. Don't do the things which you don't know to do it perfectly. This is the theater when you will be doing a hysteroscopy, you will be with your nurse. And usually in this session, your assistant will be standing and busy with counting his fingers. We are going to discuss we will have a little introduction, then we will speak about the hysterosalpingogram, hysteroscopy, and then we'll compare hysteroscopy with the hysterosalpingogram and the hysteroscopic procedures. They will speak briefly about 5 procedures done for such patient, and then we will with a little summary. evaluation of the cervix and endocervical canal and uterine cavity and the fallopian tubes, there's no doubt they are a part of to be done for infertile patients. Hysterosalpingogram and endometrial biopsy, they have been for a long time being done, and still they have got a rule. We'll discuss that. Further to this both, there is the need to visualize and evaluate the endocervical canal and uterine cavity. So both endocervical canal and uterine cavity with the hysteroscope, which had been added for these two procedures. Hysteroscopy has been used selectively for structural abnormalities that distort uterine cavity. So we used the hysteroscope for submucous leiomyomas, intrauterine adhesions, uterine anomalies, and polyps. It's not only that, but this is what we are going to highlight in this session. So the hysteroscopy had been used to evaluate uterine cavity, and the hysterosalpingogram had been used to evaluate the uterine cavity and the fallopian tubes. However, there are a lot of false positive results due to the hysterosalpingogram, due to the air bubbles, blood clot, debris, and distortion of the cavity because there was the pathology. Hysteroscopy in the evaluation of the infertility. We have to move to hysteroscopy if we have got something wrong or abnormal with the hysterosalpingogram to confirm the problem and probably to treat it. The hysteroscopy offers the opportunity to directly treat and visualize the problem. So what we are going to visualize, a submucous myoma may be diagnosed and treated, polyps may be located and removed, adhesions confirmed and treated, and foreign bodies spotted and removed. Hysteroscopy also is an excellent method to evaluate the cervix. Don't forget to evaluate the cervix. It's not only the uterine cavity. So look for if there are any scars to be ruled out in the cervical canal. There might be structural abnormalities of the endocervical folds and glands, and there might be adhesions and stenosis or stenosis in the internal cervical os, which many people, they believe it's not part of the uterine cavity. So hysteroscopy is an excellent method for evaluating uterus, so cervical canal and the uterus, where the corneal regions of the uterus, which can be seen by any other instrument or tools, uterotubal junctions, adhesions, and the small polyps acting like valve, sometimes including the osteae. You know, all of you, that there are a big list of indications for hysteroscopy for infertility: abnormal hysterogram, abnormal uterine bleeding, suspected intrauterine pathology, uterine anomalies, unexplained infertility, pregnancy wastage, planned intrauterine surgery, polyps, submucous leiomyomas, uterine septum, intrauterine adhesions, misplaced or embedded foreign bodies, and tubal occlusions. Also, they can be managed with hysteroscopy. If you compare the hysteroscopy with the hysterosalpingogram, each one have got something to do with. The hysteroscopy, you will be able to see, spot the problem and treat it. With the hysterosalpingogram, you may spot the problem, find the problem, and usually you can't do anything without it. The other reason, or the other big difference between both of them, the hysterosalpingogram is an easy procedure. It's easy to be skilled in it, and it is very cheap if you compare it with the hysteroscopy, which needs tools, good experience, and expensive. Now we'll speak about 5 issues which we said we are going to just speak briefly about them. First of all, we'll start with the symptom, which can be diagnosed, as you see, with the hysterosalpingogram. Symptom might be a small one, or it might be extending from the vagina up to the cervix, up to the uterine cavity. Usually, patients, they don't present with any symptoms, and many times you will discover them when a woman is delivering, or if she had been investigated for infertility with the hysterosalpingogram, you will find a septum or septate uterus. The treatment, if we spot that, and especially if the patient coming for infertility, the treatment is correction, and it can be done either with laser or mechanically by Caesar or by a resectoscope using either bipolar or monopolar resectoscope. Which one you are going to use depends on how good you in that procedure. So if you are good in Caesar, do it with Caesar. If you are good in resectoscope, do it with the resectoscope. However, some symptoms, they won't be easily done mechanically by the Caesar. So you need to use the resectoscope to finish it. And this paper, which was in 2022, it was for reproductive outcomes of natural pregnancy after hysteroscopic septum resection in patients with a septate uterus. This was a systematic review and meta-analysis. What they come with, the septum resection may improve the reproductive outcomes of patients with recurrent miscarriage or primary infertility. So they concentrate on 2 issues, in recurrent miscarriage and primary infertility. However, the effectiveness of the septum resection was unclear for patients who had got a secondary infertility. We have to, because sometimes we don't need to do, as I said previously, we don't need to do a procedure unnecessarily, especially if it is intervention as such. If the patient have got a secondary infertility and she came with the symptom, so probably this is not the cause of her infertility. You have to look for some other causes for infertility for her. The other paper also, it was a recent one, 2021. It was the effect of hysteroscope metroplasty in reproductive outcomes in women with septate uterus. This is a systematic review and meta-analysis as well. What they said the hysteroscopic metroplasty is effective in reducing the risk of miscarriage in patients with complete or partial uterine septum. So as we said, the complete and partial, if we do a septum removal, that will improve the chances of miscarriage. And I think the previous speaker, she spoke about that as well, and she brings the evidence for that. When it comes to the intrauterine adhesions might be because of previous cesarean section or previous evacuation or previous procedures done like hysteroscopy. It is diagnosed from the history when the patient would come with the disturbed period, little period, and if we do a hysterosalpingogram, it will be very clear, a Asherman's picture of hysterosalpingogram. Then with the hysteroscope, you will be able definitely to make a diagnosis. There are 3 types usually of adhesions: mild, moderate, and severe, and the prognosis, of course, depends on this type of the adhesions. The hysteroscopic adhesiolysis, efficacy and safety. This study included 61 patients presented with infertility, primary or secondary, or recurrent pregnancy loss caused by intrauterine adhesions. What they said, they came out with hysteroscopic adhesolysis of intrauterine adhesions is safe. This is very important and effective in terms of reproductive outcomes. Safety first, and how effective or not. They are safe and effective procedures. Of course, in the experienced hands, the outcome is significantly affected by degree of the intrauterine adhesions. If it's mild, moderate, or severe. If you have got a severe intrauterine adhesions, the chances are not as good as if it's first degree or second degree. So it's not affected rather than the other main complaint before the procedure itself, because she might have some other complaints before the procedures, like hypomenorrhea. And polyps, most of the time, you will discover them accidentally. A patient usually they don't have complaints, except if it's a large polyp. Polyps, they might be small, they might be large, they might be multiple, and might be different places of the uterine cavity. And if you are doing a transvaginal ultrasound scanning, you will be able to diagnose the polyps. The pregnancy rate after hysteroscopic polypectomy depends on the size or number of the polyps. This is the question had been asked. And the answer was hysteroscopic polypectomy of endometrial polyps appeared to improve fertility and increase the pregnancy rate in previous infertile women, with no other reason to explain their infertility, irrespective of the size or number of the polyps. That means if a woman, she have no other reason to become unable to conceive, and we find the polyp, we have to remove it, irrespective of the size or site, or it's with the pedicle or without a pedicle. Type of infertility of patients seems not to affect fertility rates after hysteroscopic polypectomy, and hysteroscopic polypectomy is a safe procedure with low complication rate, and this is another important issue. Another thought about the management of endometrial polyps in infertile women, was a many review, and hysteroscopic polypectomy of endometrial polyps appeared to improve fertility and increase pregnancy rate in previous infertile women with no other reasons to explain their infertility. Hysteroscopic polypectomy is a safe procedure with low complications rate, almost the same which came before. Endometrial polypectomy is currently justified in patients with repeated IVF failure, and this had been mentioned also in the previous session. So if we have got women who have got a repeated failure of implantation, and we find the polyp, we have to remove this polyp. Submucous leiomyomas, usually they present with symptoms, and usually with abnormal uterine bleeding. They might be discovered while we are doing a routine examination for a woman coming to the clinic, or if she is having a heavy period, prolonged with the clots. And the ultrasound will be able to spot that, to find out When we do transvaginal ultrasound scanning for submucous myomas, we have to map them, and we have to draw a sketch for that. Why? Because when we are going to operate on them, most of the time the patient will be booked for a few days, and we will forget about what's going on. So we need to map it. And just a minute, yes. The impact of hysteroscopic myomectomy on infertility and the pregnancy outcome of infertile women according characteristic of submucous fibroids. This was what they said. The hysteroscopic myomectomy had a low incidence of complications, very important, surgical procedures with good reproductive outcomes in infertile patients when the only cause of infertility was a submucous fibroid, and hysteroscopic myomectomy does not significantly impact the mode of delivery. Don't deliver her by cesarean section after that. Fertility rates after hysteroscopic treatment of submucous myoma depending on their type. And what was the came? The intracavitary submucous fibrosis measuring up to 3, type 0 and type 1 are effectively treated by hysteroscopic resection. And menstrual pattern is established in most of the cases, and fertility rates seems to be increased after hysteroscopic resection. The last one is the intrauterine foreign bodies, like devices. Sometimes patient complaining of infertility and you have got a forgotten device, or a piece of the device, or some other foreign bodies. Intrauterine foreign bodies, other than contraceptive devices and systems may affect fertility. We have got reports of 2 cases, one case of endometrial cessation metaplasia, and another case with unabsorbable suture material after cesarean section. Imagine it. And she have got through all the... So foreign intrauterine bodies should be considered in case of infertility. We have to think of that. So in summary, uterine factors accounts for less than 10% of all infertility. The hysterosalpingogram is a useful method for evaluation as the initial screening test. Hysteroscopy becomes a valuable adjuvant in the evaluation of patients with or without abnormal hysterosalpingogram, permitting an accurate diagnosis and direct treatment. Hysteroscopy is used as a therapeutic method in many conditions that may affect fertility. The addition of transvaginal ultrasonography complements the overall evaluation of the uterine cavity. Thank you very much.
Thank you, Dr. Abdelhafid Abu Dhair, for that priceless talk. Our next keynote speaker will be Professor Muhammad Abu Dabbous. He's a senior consultant gynecologist in the National Cancer Institute, Misrata. He's also the associate professor at Al-Marghab University. He's the CEO of Nabd Al-Hayah Hospital. He's the founder of the Libyan Society for Gynecological Endoscopy. He's a leading consultant in the minimally invasive gynecological surgery in our country. He's a presenting role of the reproductive surgery in infertility versus assisted reproductive techniques. He'll be talking about reproductive surgery versus assisted reproductive technologies, selecting the correct alternative. Thank you, Doctor.
Sabah khair. What a great day. Good afternoon. Welcome our guests in Libya. Thank you, Noor Al-Hayah, to give me this opportunity to talk about my topic. What's the better in our OPD practice? First of all, I'm working in my own place, Nabd Al-Hayat in Misrata, and Al-Masarra Clinic. I'm one of the committee in the Libyan Society of Gynecological Endoscopy and a consultant in the National Cancer Institute, a member of the gynecological team in Noor Al-Hayah Center. Happy to talk about the surgical view. Okay, good. Here's my team, young doctors fighting to enhance the conception. Maybe in other way, not only by medication, but maybe to help the patient by surgery, by minimally invasive surgery. Hippocrates said that we try to help, but try to not harm. That means we have to calculate everything in our OBD. When the patient comes to us, we have to calculate the cost of our treatment, cost of our procedure, what's the benefit from our procedure or our treatment, and we have to calculate the risk factor. We have a famous cartoon movie. It was a conversation between anesthesiologist and surgeon, orthopedician. The orthopedician said, I have fracture, I need to fix it. And the anesthesiologist asked him, can you give me information? So we have to treat a patient not just looking for one organ, but I have to look for the patient completely. We have to measure everything before starting the medication. Mean fertility bedeutet this component. I will talk a little bit about that statement. Professor Abudher, he said the endometrium polyp, it's diagnosed accidentally by hysteroscope. That means the ultrasound, it's a tool for diagnostic, but usually you missed some pathology in pelvic room. That's why, if we are looking to this picture, I'm talking to gynecologists, I mean young gynecologists. We have here General Electric grade. All of our clinic in Libya, maybe they have another type of grade, not that one, with high resolution. So we can see here the transvaginal ultrasound organ, it's uterus, with a little bit free float collection. But if we are concentrated, we will find here a lesion. So maybe it's a roughness in the endometrium. It's by transvaginal, not transabdominal ultrasound. So you will find this lesion, you have to treat it before you're starting induction of ovulation. We have here 2 lesions. If you are hurry up in your practice, in your work, you will not catch it. So we have here 2 pictures in Lomba Hospital in 2012. It's a polyp. What it means? That means we have to start to use a minimal invasive surgery before maybe starting induction of ovulation. Every single statement that I said, it's controversy. So it's not, you will find a lot of doctors, they are conservative. Maybe the other part, they will do this because they are looking after the pathology before starting a medication. American Association Gynecological Laparoscopy, they have advice to remove a polyp, enhance the conception. I will not talk a lot about the hysteroscopy, just a little bit here. You can see polyps, endometrium septum. All of hysteroscopic intervention can help the patient to conceive. If you are correct endometrium septum, so you have higher chance of conception. If you are remove polyp, you have another bonus for the conception, endometrium polyp as well. I think nowadays, I'm very happy to say the laparoscopy and the hysteroscopy, it's a gold standard, a gold tool helping the couples get conception. So in better circumstances, we have 30% of successful rate of our induction. our cycles from a point of view of reproductive medicine, but around 60 or 70% from our reproductive surgery. We have here a study in 2012 using routinely by randomized control trial a hysteroscope measuring the cost and effect. They have a little bit more percent of conception after failure 2 times IVF. So this is, I think it's very nice success after the hysteroscopy. This is a recommendation that say the hysteroscope is a gold standard. According to myomas, submucous myoma, according to type, we have a recommendation that after myomectomy, raising percent of the conception. Uterine septum, we have ladies, they had children already, and they have uterine septum. Some of doctors said just conservative, another said take it away. We have here 41% spontaneous pregnancy after septum resection. According to Congress rule, I think we cannot play a movie here. We have to jump to another controversy disease. This is hydrosalpinx. A lot of doctors, they have already experienced to excise it out, ligate, or leave it in bees treated with antibiotic. But the recommendation is clear from ASRM, from American Society for Reproductive Medicine: take it away, ligate it, by using the right instrument. Still, we have insufficient data other procedure, I mean salpingostomy, or treated with aspiration through or treated with antibiotic. Salpingectomy by using monoelectricity. So the electric surgery is very important to know before you use it. If you make a salpingectomy or any procedure closer to the ovary, so it can harm the reserve, but usually there is no any harmful. This is a video. Unfortunately, I cannot show it to you. Massive adhesion. The ovary, it's hanging up. I think there is no way to reach it by pickup because the ovary is already far away from the pelvic room. That's why the laparoscopic adhesolysis for such patients very, very important. Endometriosis, it's also a tema which all the time is controversy of treated in the infertility patient. We have our statistic will be presented by Dr. Blau. Just I want to say the deep infiltrate endometriosis should be treated with expert doctors. Also, the medical therapy alone make no difference in pregnancy. Surgical treatment of early stage of endometriosis improve the fertility outcome. Advanced stage had no big rule with IVF. The endometriomas, if less than or if more than 3 centimeters, only be excised if there is a symptom. In the past, it was we was helping our patient by minimal invasive surgery. Nowadays, the assisted reproductive technique is jumping forward, but after experimental and animal trial, nowadays we have a very good equipment in endoscopic surgery. So I think we have to enhance the conception by using the minimal invasive surgery rather than the medication. That's why we open right now the way by under the supervision of the Libyan Society of Gynecological Endoscopy, the courses for young doctors to make a training more and more, and just take step away from the surgeons. They know nothing about our field. They excise everything out, and we harm our patient. So the gynecologist, they have to stick to the other the expert gynecologist, not to go to the surgeon to do the minimal invasive surgery. Thank you very much.
Thank you, Dr. Mohammed, for that intriguing speech. For the final speaker today, we have Dr. Aya Blau. She's a doctor of obstetrics and gynecology in Jalal Maternity Hospital. She's also a trainee in the Arab Board Council. She's a member of Dr. Mohammed Abu Dabous's team of minimally invasive gynecological surgery and reproductive medicine. She is the presenter and author of the role of laparoscopic in diagnosis of endometriosis in patients with endometriosis-associated infertility. The topic she will be debating today or talking about is the role of laparoscopy, the diagnosis of endometriosis, patients with endometriosis-associated infertility. The stage is all yours.
Thank you. Good afternoon, ladies and gentlemen. Thank you, الحياة Conference Scientific Committee, for this opportunity for me to present our research paper. Okay, so this is our team. Okay, I will present our paper about the role of laparoscopy and the diagnosis of endometriosis in patients with endometriosis-associated infertility. First, as a brief introduction, what is endometriosis? Endometriosis is a chronic inflammatory disease defined as the presence of endometrium-like tissues outside the endometrium and myometrium. Endometriosis is estrogen dependent, so it is a disease of women in a reproductive age group. The exact prevalence of endometriosis is unknown, but estimate ranges from 2 to 10% in general population, but it reaches up to 50% in infertile women. The exact etiology or the cause behind endometriosis is unknown, but as we know, there is several hypotheses suggesting the pathogenesis and the process of this disease development. But the retrograde menstruation theory, which is introduced by Sampson's, or known as Sampson's theory, is the most central one, as retrograde menstruation, where menstrual blood flows back to the fallopian tubes, that occurs in 90% of women, but not necessarily causes endometriosis in all of these women. Okay, patients with endometriosis might be asymptomatic for long periods of time, or might present with a wide spectrum of symptoms, maybe non-specific symptoms, but suggest endometriosis. And of these symptoms is dysmenorrhea, dyspareunia, chronic pelvic pain, dyschinesia and dysuria sometimes, and infertility, which is our concern for the day. Endometriosis causes infertility. The exact process or the exact mechanism of how endometriosis causes infertility is still unclear, but there are several biological mechanisms through which that happens. And of these mechanisms is adhesions, so distorted pelvic anatomy, altered peritoneal function, altered hormonal and cell-mediated function, endocrine and ovulatory abnormalities, and impaired implantation. So, as I mentioned, endometriosis exact prevalence is unknown, but endometriosis is a quite common disease, and due to the accompanying ailments of the disease and the chronic nature of this disease, it is considered as an important medical, social, and economic problem. Also, we cannot neglect the major psychological impact of this disease in patients with endometriosis. So, 3 main entities of pelvic endometriosis have been identified, either ovarian endometriotic sets, superficial peritoneal endometriosis, and deep infiltrating endometriosis. How can we diagnose endometriosis? Preliminary diagnosis is done through, first, good clinical history taken for symptoms suggesting endometriosis, and then we have physical and gynecological examination, palpation for any pelvic masses, bimanual examination of uterus and adnexia for any nodularity, and also we have tenderness in the posterior vaginal fornix, which is the commonest finding in patients with endometriosis. And then, after history examination, we have to choose the appropriate imaging modality to reach or to approach our diagnosis. We have transvaginal ultrasound, which is available in every gynecological OPD. Transvaginal ultrasound is highly sensitive in diagnosing ovarian endometriomas, and a Cochrane meta-analysis found that the vaginal ultrasound approaches the sensitivity and specificity needed to replace surgery in detecting ovarian endometriomas. But the problem with transvaginal ultrasound is that it is of no use for diagnosing peritoneal endometriosis or deep infiltrating endometriosis. And then we have MRI, which plays a vital role in diagnosing and pre-surgical assessment for endometriosis, as provides a detailed information about endometriotic lesions, about their location, and about the endometriomas in ovaries. Then, after imaging modalities, we have the serum biomarkers, but as Shri recommends not to use the biomarkers as a diagnostic tool, we have CA125, which is raised in endometriosis, but it's non-specific because it's expressed by any tissues covered with coelomic and Müllerian epithelia, so we cannot depend on it in the diagnosis, but it's highly sensitive, or its level are higher in moderate to severe disease. Then we come to minimal invasive surgery, laparoscopy, which is the aim of our study. Unfortunately, this is a video, but we cannot play it. This is a 26-year-old patient with primary infertility for 2 years, and with diagnostic laparoscopy, she was found to have adhesions on the left side, and then she has a left ovarian endometrioma. Okay, now the role of laparoscopy in diagnosing endometriosis. Laparoscopy provides the ability to visualize pelvis, to directly visualize endometriotic lesions. It gives the ability to take biopsies for histopathological examination and to confirm our diagnosis. Also, the magnification feature of laparoscopy makes it superior to laparotomy in detecting small peritoneal lesions that might be missed in open surgery. Good. It has played, unfortunately. So as we see, there is the left side ovarian endometrioma. This is part of our work. And here, this, in the second clip, this is more, yeah. If you can play it, yes. Now, this is a 35-year-old patient with primary infertility for 4 years. She had no past surgical or past medical history. And then by diagnostic laparoscopy, she was found to have adhesions multiple tube ovarian adhesions. As well, we can see there's a spot of endometriosis. As our surgeon is dissecting the adhesions, there's also signs of PID all over. Here in the pouch of Douglas, an arrow will show us another spot of endometriosis that was excised and then sent to histopathological examination. So, as I mentioned, endometriosis by laparoscopy, it can be visualized as adhesions, fibrosis, bilateral endometriomas, either unilateral or bilateral, or it could be a combination of all of that. Okay, so the objective of our study was to evaluate the role of laparoscopy in diagnosing endometriosis with patients with infertility. We included in this retrospective study 226 women, all with infertility, either primary or secondary. The age range was 19 to 45 years. 145 patients had complained of chronic pelvic pain, while 42 other patients had dyspareunia. Gynecological examination for all patients was remarkable, and they had diagnostic laparoscopy and hysteroscopy, by the way. The findings were as follows: 167 patients, that represents 74%, had pelvic adhesions of varying degrees. 44 patients, that represents 19%, had no pathology at all, and 39 patients, which is 70%, were found to have or discovered to have endometriosis, ranging from mild to severe stages of the disease with massive adhesions and presence of endometriomas. The diagnosis in these cases was by direct visualization of the lesions and by histopathological examination of biopsies taken from the abnormal areas. Other findings in this study were ovarian cysts in 25 patients and uterine fibroids in 20 patients. So 47% had pelvic adhesions and 17% had endometriosis. As a conclusion, laparoscopy plays a critical role in diagnosing endometriosis, but according to ESHRI Guidelines 2022, that called for a refinement of the concept of using surgery as the first line or as a first or the only diagnostic tool, and we have to depend more on the advances of imaging modalities. Diagnostic laparoscopy should not be used directly. It should be preceded by good clinical history taking, by physical examination of the patients, and by choosing the proper imaging modality to approach the diagnosis. The advantage of the use of laparoscopy in the diagnosis is that it reduces the delay in diagnosis because due to the wide spectrum of symptoms, endometriosis might remain undiagnosed for years, that reaches 8 to 12 years. And that time counts for patients, especially with patients with infertility, and patients who are suffering of chronic pelvic pain that affects the quality of their lives. So despite advances in diagnostic imaging for endometriosis, the data demonstrate the disease cannot be ruled out until the pelvis is directly visualized and biopsies are taken of abnormal areas. At last, I just want to say, diagnostic laparoscopy is not yet antiquated, but it should not be considered mandatory. It should not be considered as the first-line diagnostic tool for endometriosis, but it remains the gold standard for diagnosis, and it's a gateway to treatment. Thank you.
Thank you, Dr. Aya, for that interactive presentation. Now we'll open the floor for discussion for our final session. Number 3, the governors of the session will be the chairman. If anybody has a question or remark, could they please put their hand up? One of the assistants will bring you the mic.
Thank you, Professor Abdul Hafiz, and thank you, Professor Abu Tabbous. Thank you, Dr. Aya, for this nice lecture. And now the floor is open for discussion. Maybe.
Thank you, Dr. Abu Tabbous, for your activity in endoscopy surgery in this area of our country. My question is, you didn't mention anything about the open surgery. Still, we are practicing open surgery for reductive surgery, which is very, very essential. You still have limitation in your laparoscope. If you have a fibroid type 2 submucous and you accidentally open the cavity, it's very difficult to resocialize the cavity in a proper way with your laparoscope. So would you agree with me that still we have chance for open surgery? Number two, for the second speaker, 74% endometriosis is very high rate comparing to international figure. So I think you have to review your characteristic feature to diagnose endometriosis by laparoscope. Thank you.
I think the open surgery for helping patient to conceive is almost in the history. So we can help our patient by minimal invasive, even if we do a perforation or a complication by using intrauterine, by using resectoscope, for example. Reach to intercorporeal, extracorporeal stitch using laparoscopy. I'm not talking about uterus, I'm talking about small bowel. If there is any bowel injury, we can dealing with. So that's why it's in our area, there is lack of skills. We have to maybe work on that. So trying to make a training, sharing ideas, make workshops, invite the experience overseas, just to try to help our patient minimally with keyhole surgery, not to open it. For example, endometriosis is very bad if you are going to laparotomy. So never ever this patient will be happy after the surgery. So that's why I'm fully agree with you. There is lack of experience, lack of gaining skills. But nowadays, we are stronger than before. We can under support of different societies, making diplomas or workshops, training, just sharing and operating our patient together. I mean gynecologists together, not with the general surgeon. This is the first question. I will move to the second question.
Just a correction, Dr. Hamouda, the results were 167 patients. That represents 74% had pelvic adhesions, not endometriosis. The percentage of endometriosis was only 17%. That is 39 patients out of 226.
Okay. Thank you, Dr. A. Thank you, Dr. Abu Dabbous. Really, I agree with you, Dr. Mohammed. I agree with you. We have to propagate experience in laparoscopy. We can move from open surgery to a laparoscopic era. And this is possible. Everything could be done by a laparoscope, but we need an expert. So if you have any cases or something like that, you have to refer it to the expert and learn from him and take the appropriate courses and diplomas. And I agree with you, we have to move to the era of laparoscope and leave the era of open surgery. Thank you.
Yes. Dr. Muhammad, Dr. Aya, thanks a lot for your presentation. But we should know what are the indication of laparoscopy and the hysteroscopy in evaluation of infertile. Both are not a routine. The indication of laparoscopy, if we have abnormal ultrasonography or hysterosalpingography or a history or a clinical examination suggestive of pelvic disease, but not a routine. For Dr. Aya, you mentioned that the last ISHRI guidelines mentioned that laparoscopy is the golden standard, is the golden method for diagnosis of endometriosis. No, it is removed. Mentioned that imaging, and by imaging, transvaginal ultrasonography or MRI, is the golden standard for diagnosis of endometrioma and deep infiltrating endometriosis, while laparoscopy is still the golden standard for diagnosis of peritoneal endometriosis. Right? We should differentiate between these three types of endometriosis. Shukran.
شكرا.
I fully agree with you. It's not a routine, it's not the first line, but we have accidentally pathology. And patient already underwent maybe 1 or 2 cycles of induction of ovulation by expensive medication. So it's a line still, not for every patient, but I touched the successful rate of the conception after diagnostic hysteroscopy and diagnostic laparoscopy. Patient 12 years suffering, and she underwent many trials, and she took a lot of medication. Only hysteroscope, laparoscope, proper way, she is pregnant. This is the first comment.
Dr. Abu Bakr, according to ESHRI Guidelines 2022, laparoscopy is no longer the gold standard for diagnosing endometriosis. And as I called, ESHRI described the use of surgery as a diagnostic tool an outdated dogma. That means it's no longer used to be used as the first diagnostic tool. And as I mentioned, it should be accompanied or preceded by good clinical history and physical examination. And it's only for patients with unremarkable gynecological examination.
And I quite agree, the ISHRI recommending the use of endometriosis infertility index, right? And for this, we should use the laparoscopy. And they mentioned that this is the cornerstone in deciding the line of the treatment. And this index depends on the history and also on the laparoscopic finding. And then you have a score, and you can expect the pregnancy in the coming first year. Shukran.
Thank you very much. My name is Ihab Abu Marar. I'm coming from Ireland. I was trained in Germany, so part of my fellowship training was to be trained for the minimally invasive, both laparoscopy and hysteroscopy. So I am kind of, sorry?
Please introduce yourself.
Ihab Abu Marar, I mentioned, Ihab Abu Marar coming from Ireland. So the issue of infertility and minimal invasive, we cannot separate them at all. They are directly linked, but we have to handle them in the proper way. Meanwhile, I'm catching the issue from the middle, of which, if I'm having any signs and symptoms which indicates any pelvic abnormalities that could be interferentially and resolved by the minimal invasive, I will go for that. Other than this, conservative treatment by infertility treatment by gonadotropin will resolve the issue. Let me tell you something. I will take your study as an example. You mentioned that 74% was found to be adhesion. Those adhesions are not necessarily to be from the endometriosis. Could have been a pelvic inflammatory disease which could have been resolved by the antibiotics. So this is part one. But in the other part, I would mention as well that in cases of recurrent implantation failure of no known cause and no abnormalities, hysteroscopy has a golden standard in here. So both should be applied separately, but dependently, and at the same time in the proper way by expert hands. Thank you.
Thank you. Dr. محيشي.
محمد حيشي.
هو النقاش ممكن يطول في هذا المجال، ولكن due to long experience in endoscopy, so I want to say there is nothing named routine in endoscopy. No way to say I will do routine laparoscopy or routine hysteroscopy. Wouldn't give any good to the patient. About the, I didn't see in your ayah, in your slides, any endometriosis. I seen adhesions due to the common one is pelvic inflammatory disease or bowel disease or so. There's no endometriosis. The number of endometriosis is not much, and you can't diagnose it except the peritoneal, as Dr. Abu Bakr. Yeah, sometimes silent endometriosis, peritoneal, so you give clue, maybe you do laparoscopy if you to the end. Otherwise, you can't diagnose it by vaginal ultrasound or chocolate cyst. You can't diagnose, very easy. And also with MRI. But in propaganda, we know. So you have to calculate again what patient for laparoscopy, what patient for hysteroscopy. Even for hysteroscopy, there is no indication, routine indication before doing IVF. No, I'm doing IVF now 40 years. I never put this as real routine indication. Do it if indicated. And you can't diagnose. I don't know what's happened to you. You can't diagnose the vaginal ultrasound, everything in the cavity. Yeah, some niche or history will compensate what you missed in vaginal ultrasound. So you have to take good history and examination, do vaginal ultrasound, and you reduce what you are doing. And thank you, because it is a lot to discuss.
Thank you. Thank you, Professor محمد سلامة. نعم. دكتور محمد سلامة. ثانية دكتور ثانية. دكتور سلامة بعد كده.
Thanks for this fruitful discussion. Now, all of us are on the stage. There is an evidence-based medicine, and we have to respect the evidence-based data in our practice.
Yes.
Number one, Professor Abdul Hafiz. Sorry, he is my beloved friend, but endometrial biopsy is not a routine investigation for uterine factor, full stop. Number two, when we are removing a polyp, we must send for histopathology. Why? Because many of the uterine polypi, in more than 40% proved to be malignant. That is why recurrence is always present. And the polypi for infertile patient, especially in ART program, if the size, this is an evidence-based, not the Salama talk, if the size is more than 1 centimeter, must be removed. Why? Two factors. Number one, as Professor said, it increased miscarriage rate by 3 times, but doesn't affect the occurrence of pregnancy. The number one. When we are dealing with hysteroscope for myoma, our reference, Dr. Dabbous, the FIGO classification of myoma, type 0, type 1, type 2. Dr. Maheshi said, type 0 and 1, hysteroscopy. Type 2, it is an experience, an instrumentation, and availability of the resectoscope, and sometimes two-stage endoscopic, hysteroscopic surgery. As regard the laparoscope, Dr. Aya, I am respecting your talk. It is very nice. But we have to differentiate between endometriotic patient complaining of pain and infertile endometriotic patient. This is an evidence-based. For infertile endometriotic patient, medical treatment is the gold standard, anyhow, by any mean, grading. But for infertile patient, no place for medical treatment, as Professor Maheshi said. Your talk very nice, but Dr. Dabbous, it is an brainstorming. It is, the title was laparoscopy or endoscopy versus IVF. No answer. لا no answer. يعني التوك نهاية وصورة البنت الجميلة اللي كانت في الآخر بنتك ولا مين؟ بنتك خلاص مش هنتكلم.
Thank you very much. I will go back to our videos and whether it's endometriosis or not. It looks not like endometriosis, but histopathological was endometriosis. So that's why it's mentioned in our study. This is the first point. The second point, whether it's the adhesion, this is a little bit, it's small adhesion, it's not affected the infertility. Those patients infertile. And we have here genius doctor, they are already treat such patient, and such patient need really minimal invasive surgery. Not all our patients is routinely for endoscopic surgery. We are selecting our patients. It's not a routine procedure. We are selecting our patient, but we have to help. If the patient is suffering years back and she received a lot of conservative management, induction of ovulation, and we have to do endoscopic surgery, hysteroscope and laparoscope as diagnostic, but not for all of patients, not a routine procedure. This is my comment.
Okay, thank you, Professor
thank you,
Mohammed. Dr. Nisreen, تفضلي.
شكرا. Thank you, Dr. Mohammed. Thank you, Dr. Aya. I want to ask you about what do you counsel the patients before they go for laparoscope?
Actually, we have to.
In other words, did you tell them it's just a diagnostic procedure or a therapeutic procedure and you will get pregnant after that? Thank you.
All the time we are facing this question. Am I pregnant after this procedure? We don't know, just we are trying to help. What indication? I think this is your question.
What kind of help did you offer for them?
What kind of help? Hysteroscope, laparoscope. Based of what? Based of what? Based of proper history, proper examination, mandatory transvaginal ultrasound. It's mandatory. Transvaginal ultrasound, we are not using abdominal ultrasound anymore. For myomas, we are going resectoscope until to reach a level, and then we are combined with laparoscope. We are removing the myomas hysteroscopic, laparoscopic together. And we are not.
Dr. Mohammed, I think Dr. Nisreen, she asked about what's your counseling to the patient. How do you counsel your patient?
What do you tell the patient? Always we are facing patients.
One sentence.
What is your percentage for success for IVF? That's what they're asking us.
Regarding counseling, Dr. Nisreen, regarding counseling the patients, it depends on our examination and the findings in our examination. If we have a visible, clear pathology, so our intervention or our surgery is going to be therapeutic before anything, and we are always discussing our expectations with our patients. So the patient before surgery, she knows the plan of her surgery, she knows what is going to be what is going to happen. For example, in cases of hydrosalpinx, and we are discussing the wishes of the patients. Some patients, even who are indicated for salpingectomy, refuse salpingectomy. Some patients discuss with us that it depends on what you are going to find, do what is best.
دكتورة أنت ممكن ما فهمتيش السؤال. أي حاجة بتديريها عندك professional diagnosis. When patient want to do laparoscopy or cystoscopy, what's your professional diagnosis? She's going for this, what for? Not only for infertility. Infertility, not jumping for laparoscopy or cystoscope. You have to treat it medically, conservative, so on and so. But you have, that's her question. Because you have to take the consent. And right, she's going for laparoscopy to do so and so.
Yes.
Diagnostic.
If it's only diagnostic,
so
we
you
are.
take all your patient diagnostic.
No, when we reach the point.
This
of
is Muhammad
surgery,
should be answered.
Yeah.
There is nothing named routine diagnostic.
Yeah. If we saw a pathology, I mean, like hydrosalpinx, so it's not diagnostic tool. So we will counsel the patient for salpingectomy. Conception. Success rate, I said already, we have 100%. No, there is no 100%. I'm sorry to tell you 100%. It's not 100%. We We have our studies, ongoing study from our patients. I promise you to bring the result. How many patient is pregnant after laparoscope and hysteroscope?
Muhammad, thank you very much. We have to close the session for the lunch break. Thanks a lot for everybody. Thank you.
Thank you.
One last question. دكتور اوكي اتفضل. معلش يا دكتور محمد اتفضلي. اخر دقيقتين وخلاص. الدسكشن مفيد يا جماعه. ده مش برزنتيشن يعني. معلش يا بيه مش واصله ولا حاجه من الاول. اتفضلي يا دكتوره.
Remain seated for the last question, please. I'm sorry for the misconvenience.
Assalamu alaikum. I have one question for Dr. Abdel Hafid Obot here about the role of hysteroscope in infertility. I want to ask him if he did doing a real study about infertile patient and follow them. Because I have did one real study at 2010 in Ibn Sina Teaching Hospital. My result of study, the hysteroscope should be gold standard in the infertility and explain infertility and implantation, recurrent implantation failure, especially in younger infertile women less than 40 years. Thanks.
Okay. خلاص اوكي.
أنا متأكد أنكم كلكم جعانين.
تمام.
لكن خلونا we speak.
لو تحب نجاوب بعد الغداء بيه اوكي.
برنسب.
تحب نجاوب بعد الغداء؟
خلوه بعد الغداء.
اوكي مفيش مشكلة. خلاص يبقى هنجاوب السؤال ده ان شاء الله بعد الغداء. حضرتك تقول لنا وبعد كده نبدأ السيشن. اوكي thank you all and now go to lunch. See you.